ফ্রেডরিক এবার্ট স্টিফটিং FES এর পক্ষ থেকে আপনাদেরকে স্বাগত জানাচ্ছি ওয়েলকাম টু দিস ডায়ালগ or rather I should call it workshops. The topic is the future of work in Bangladesh. So এই শিরোনামে আমরা একটা গবেষণা হাতে নিয়েছি এবং এই ফিউচার অফ ওয়ার্কসের আন্ডারে আমরা বেশ কয়েকটা প্রায় এই পর্যন্ত 4টা গবেষণা করেছি বিভিন্ন থিমের উপরে সো অ্যাজ উই নো দ্যাট যে আমাদের যে টেকনোলজিক্যাল একটা রেভলিউশন হচ্ছে ফোর্থ ইন্ডাস্ট্রিয়াল রেভলিউশন হচ্ছে 4IR তার ফলে কিন্তু আমাদের যে ইকোনমিক অ্যাক্টিভিটিস এবং লাইফস্টাইল দ্য ওয়ে উই লিভ দ্য ওয়ে উই ওয়ার্ক দে উইল বি অ্যান ইম্প্যাক্ট সো ইট উইল ইনক্রিজ it is expected to increase the efficiency of our work and also it might save also a lot of time, but on the other hand there's also a fear that it might also displace the many laborers from the workforce. But again on the other hand there will be also a lot of opportunities for work, but in order to take advantage of those work, we need to also scale up, reskill and capacity building of the workforce so that they can take advantage of those new jobs which are created. So এই থিমের উপরে আমরা বলেছি যে আমাদের as you know that we are at the Center for Policy Dialogue we work on economic issues and social issues. In no way we have expertise on the technical aspects, technological issues. So the main objective of this research was to to look into the policies of the on the technological issues. So what are the policies and how they are useful in terms of adopting technology, in terms of access to technology, in terms of preparedness of human resources. So how ready Bangladesh is in order to adapt to the new situation. So we point of view theke, and as you know that in the end no policies can be implemented without finance. So there is also a need for fiscal policies which can have implications, be it for ICT sector, be it for healthcare, be it for trade or anything. So that's why we wanted to look at that what can be done in terms of upskilling, reskilling the human resources, and also in terms of taking advantage, because technology আসলেই তো হলো না, টেকনোলজি সবার কাছে অ্যাক্সেস থাকতে হবে এবং সেই সুবিধাটা সবার যাতে থাকে সেটি একটি। সো সেই পয়েন্ট অফ ভিউ থেকে যে 4টি থিমের উপর আমরা কাজ করেছি, এর আগে 2টো বিষয়ের উপর কাজ করেছি আমরা, সেটা হচ্ছে যে একটা প্ল্যাটফর্ম ইকোনমি। তো আজকাল আমরা দেখছি যে প্ল্যাটফর্মের সুযোগ নিয়ে ই-কমার্সের মাধ্যমে অনেকে ট্রেডে আসছে, অনেকে বিজনেস এক্সপ্যানশন করছে, অনেক নারীরাও সেখানে জড়িত হচ্ছে এবং ইট ইজ ইন এ ওয়ে ওপেনিং আপ অপরচুনিটিস। বাট অন দি আদার হ্যান্ড হোয়াট আর দ্য লিমিটেশনস, হোয়াট আর দ্য predicaments, bottlenecks and constraints in order to expand that, ওইটা আমরা আলোচনা করেছি। এবং দ্বিতীয় আরেকটি বিষয় ছিল যে the trade in services, internationally আমরা যে ধরনের ট্রেড করে থাকি through online, through digital technology, digital platform, সেখানেই বা কি ধরনের সমস্যা আছে, not only infrastructure related, but also as I have mentioned that in terms of policies, so cross border trade করতে গেলে কি ধরনের পলিসি, ওই দুটো থিমের উপরে সেগুলো আপনারা যদি আমাদের ওয়েবসাইটে যান সেগুলো লিংক আছে, সেগুলো কোনো একটা সময় ওনাদেরকে পাঠিয়ে দিতে পারেন। আজকে যে দুটো বিষয় নিয়ে আমরা আলোচনা করব, ওয়ান ইজ দি ট্রান্সফর্মিং বাংলাদেশ হেলথ কেয়ার ইন দ্য ফোর্থ ইন্ডাস্ট্রিয়াল রেভলিউশন, দ্য পিরিয়ড অফ ফোর্থ ইন্ডাস্ট্রিয়াল রেভলিউশন। অ্যাজ ইউ নো দ্যাট যে এই টেকনোলজির মাধ্যমে অনেক হেলথ কেয়ার পাওয়া ইজিয়ার হচ্ছে, বিভিন্ন দেশে তো উন্নত দেশে সেই সুযোগ নিয়ে হেলথ কেয়ার সুবিধাটা বাড়ছে। আমরা কিভাবে সেটা পেতে পারি, সেটার প্রিপেয়ারনেসটা কেমন হতে পারে, এটা তো একদিকে এন্ড রেজাল্ট যারা হেলথ কেয়ার ফেসিলিটি নিচ্ছে যারা কনজিউমার, বাট অন দি আদার হ্যান্ড এট দ্য ব্যাক এন্ডেও যে আমাদের রিসার্চ অ্যান্ড ডেভেলপমেন্টের জন্য হাউ ক্যান ইউ ইউজ ফোর্থ ইন্ডাস্ট্রিয়াল রেভলিউশন লাইক রোবটস, ব্লকচেন অ্যান্ড অল all these সেই রিসার্চের নতুন নতুন রিসার্চ করে নতুন নতুন ওষুধ বলি বা নতুন নতুন ট্রিটমেন্ট পদ্ধতি সেখানেও কি ধরনের টেকনোলজি ব্যবহার করা যেতে পারে অ্যান্ড অলসো সেটার জন্য কি ধরনের পলিসি সাপোর্ট দরকার হবে সেই বিষয়গুলো এখানে নিয়ে আসা। এই আপনাদেরকে যখন আমরা ইনভিটেশন দিয়েছিলাম তখন একটা ছোট্ট সামারি দিয়েছিলাম যে আমরা সেখানে কি দেখতে চাই হেলথ কেয়ারের ক্ষেত্রে। সেটা হচ্ছে যে টু হোয়াট এক্সটেন্ট দি হেলথ কেয়ার সিস্টেম অফ বাংলাদেশ ইজ টেকনোলজিক্যালি প্রিপেয়ার্ড ফর দি ফোর্থ ইন্ডাস্ট্রিয়াল রেভলিউশন। তারপরে হচ্ছে will increased use and adoption of technology such as blockchain and other cutting edge technology be beneficial for the healthcare sector for Bangladesh? What are some of the challenges attached to the adoption of technology in the healthcare services? তারপরে হচ্ছে যে how will fourth industrial revolution disrupt the existing relationship between healthcare providers and patients? So এটা হচ্ছে হেলথ কেয়ারের উপরে। আরেকটা হচ্ছে যে আর্টিফিশিয়াল ইন্টেলিজেন্স অ্যান্ড ইটস ইম্প্যাক্ট অন ইনফরমেশন টেকনোলজি সার্ভিসেস। সেখানেও আমরা দেখছি যে এখন কীভাবে কতটা পেনিট্রেশন হচ্ছে বাংলাদেশের আইটি সেক্টরের উপরে এই ফোর্থ ইন্ডাস্ট্রিয়াল রেভলিউশনের টেকনোলজিগুলো এবং ওয়ার্কফোর্স রেডি কিনা অ্যান্ড সেই ওয়ার্কফোর্সের স্কিল ডেভেলপমেন্টের জন্য কী দরকার অ্যান্ড গভর্নমেন্টের পলিসিগুলো কী ধরনের দরকার হবে। এর আগে মেনি অফ ইউ হ্যাভ given us time in terms of joining our expert group meeting also and in terms of giving interviews through telephone. সেই জন্য আপনাদের নলেজ আমাদের খুব এবং এক্সপার্টিজ আমাদের খুব কাজে লেগেছে। as I have said that we don't have any expertise on that. Many thanks once again for sparing your time and also for coming today once again. Thank you very much. So আমরা ছোট্ট প্রেজেন্টেশন খুব ছোট রেখেছি এবং এখানে যারা আছেন they are all experts in their own field, so we don't want to make we have nothing to give you knowledge on this but to initiate the discussion. So short করে আমার দুজন কলিগ ইয়াং কলিগ তারা প্রেজেন্টেশন দেবে। শুরুতে আমি যেটা যে আর্টিফিশিয়াল ইন্টেলিজেন্স অ্যান্ড ইটস ইম্প্যাক্ট অন ইনফরমেশন টেকনোলজি সার্ভিস সেক্টর এটাকে একটা ওভারভিউর মতো দেবে খুবই ব্রিফলি। তারপরে হেলথ কেয়ারের উপর যাব, তারপরে আপনারা যারা আছেন আপনাদের কাছ থেকে আমরা শুনবো। সো এখানে তার আগে আমি অবশ্যই এখানে যে আমার কলিগ মিস্টার সাধন কুমার দাস, প্রোগ্রাম কোঅর্ডিনেটর ফ্রেডরিক এবার্ট স্টিফটুং বাংলাদেশ অফিসের, উনি দায়িত্বে আছেন। সাধনকে বলবো ওনার কিছু বক্তব্য দেওয়ার জন্য। থ্যাংক ইউ।
Thank you, Appa, for giving me this floor. First, I am also welcoming you from AFES and also from our resident representative, Felix Kulbich, who is not with us today, but he has conveyed his good wishes to you. He would be really enlightened if he were with us, but as he is on his holidays, so he is missing his participation and also being enriched with your input. So now I am telling about AFES as well as the background of the cooperation with AFES with CPD. And I think I will also set the tone of this workshop maybe. You may know about Friedrich Ebert Stiftung, AFES. This is an oldest political foundation in Germany with a rich tradition in social democracy. The foundation owes its formation and its mission to the political legacy of its namesake Friedrich Ebert, the first democratically elected German president. AFES Bangladesh always work with its partners, including the Center for Policy Dialogue, CPD, to implement projects to facilitate inclusive dialogues on social justice with a focus on labor rights as well as sustainable and socio-economic development. As part of our long-term program, the Futures of Work that already mentioned by Fahmida Appa, AFES Bangladesh jointly with CPD has been analyzing potentials and challenges of digitalization and automation of Bangladeshi economy and engaging concerned stakeholders in dialogues so that we can create new discourses as well as help to build a knowledge society that will promote the benefits of digitalization in shaping up the futures of work. Digitalization is not definitely a myth, rather it has been strongly updating and penetrating our economy, society, politics, and everywhere. It has the power to change the traditional status quo that was said to continue the malfunctioning and malgovernance. Thus, policy reform measures don't bring changes in such status quo. In such situation, digitalization and technological innovation have come to us as a blessing. Bangladesh has set its vision of digital Bangladesh, and there are lots of success stories. Digitalization has broken the historical pathways of malgovernance. At the same time, digitalization and automation have been welcomed in the industries to create more jobs, to upgrade the quality of production, and to reduce the production time. Also, strongly increase accessibility to healthcare. In this context, our partner CPD, with our support, found four key important areas that already mentioned by Fahmida Appa. On these four areas, we are working together. In the meantime, two policy papers have already been released. And now we are working the other two papers. One on this health sector, and in this 4 hour, and the artificial intelligence. Now we are here to get your expert opinion on healthcare as well as on artificial intelligence. And these two papers will be have already been drafted, and your input will enrich the findings of the papers. We sincerely pay our gratitude to Dr. Fahmida Khatun, Mr. Saud Yusuf Sadat, and Ms. Nadia Naurin for writing these papers and for willing to be engaged in this dialogue event. It is always great to have CPD beside us to think new and to do new for creating and reshaping development discourses of Bangladesh. It is our great honor to have some academics, successful entrepreneurs, tech specialists, scientists, and health specialists with us. That, like your innovation and works, are impacting the society and economy a lot to create a new future of Bangladesh. Finally, we are indebted to Dr. Fahmida Khatun for chairing today's session. Thank you.
Thank you, Shadhun, for those kind words. So let's start. Let's hear from Nadia, Miss Nadia Naurin, who is a program associate at the Center for Policy Dialogue. So Nadia, you have 10 minutes?
Yeah.
Okay. Just be very brief. So.
Yes, ma'am. Thank you, ma'am, for the opportunity, and thank you everyone for coming here and sharing your time with us. So as it was told earlier, that this study is a part of the Future of Work program. This study is conducted by CPD jointly with FAS, and I'll be very brief about the study and take your advice and inputs for further inputs. So the study is led by Dr. Fahmida Khatun, and research support was received from Mr. Sadat Yusuf, our senior research associate. So let me the presentation is structured into some parts. That is, firstly, I'll talk about the introduction and our objectives of the paper and discuss the conceptual issues, and I'll talk about a little briefly about the IT service sector and the workforce and employment in the IT service sector in Bangladesh. Later, I'll move on to opportunities and challenges that emerges because due to the 4IR in the IT service sector. Lastly, we'll go for the policies and legislations for IT sector in Bangladesh. So we know that the world is going through the phase of fourth industrial revolution, and it is changing the nature of work and services in various sectors. Especially in IT service sector, it is embracing the 4IR more than any other sector. Organizations in the IT sector are focused on deploying the advanced technologies more than any other sectors to enhance the productivity and improve customers' experiences. And we'll focus more on the artificial intelligence, blockchain, cloud computing, RPA, that is robotic process automation, big data, machine learning, and so on. So the global IT sector is growing over the years, and we can see that Asia at 32% is also anticipated to make a sizable contribution to the global IT industry, which we looking ahead, the global sector is forecasted to continue growing at a 5% compound annual growth rate until 2024. When in Bangladesh, when we see that the automation, even the automation is going on in different sectors like telecom, banking, pharmaceuticals and RMG, IT sector is adopting it more, and it is emerging with service offerings generally range from transactional IT ADM and IT help desk. So we came with our objectives for these studies, that we want to understand the 4IR technologies entrance in Bangladesh IT service sector. We want to analyze the implications of 4IR on employment, which is we want to see if the workforce is ready for the 4IR intervention. And later we want to review the existing policies and initiatives taken by the government to address the needs of IT service sector, that if the sector is prepared to take in the 4IR. And lastly, we will recommend some of the measures for preparing the workforce for employment in the IT service sector. So the definitional conceptual issues are, even though it's known to every one of us here, but I'll still like to talk about it a little bit, that the 4IR technologies are differentiated in several ways. That is, inventive way in which hardware, software and connectivity are configured, reconfigured and combined to accomplish ever higher goals, collecting and analysis of huge amounts of data, continuous interaction of AI, and blurring of the physical and virtual components of output. Next, if we talk about the IT services sector at a glance, that is, the IT services sector comprises businesses which provide IT consultation or information processing services to other businesses, and it's one of the components of IT service sector is IT enabled services, and that is also very important these days. As the world has become more digitized and all sectors develop significantly more capable, IT businesses need to stay up with growing process, introducing and increasing innovation. Next, I want to talk about a little bit about the implications of 4IR components in IT service sector. Even though I will not go over all of the components, I want to focus more on AI. Industry 4.0, that is 4IR, is projected to be enabled by AI solutions along with other enablers like industrial IoT devices and platforms in the IT sector. There are others like machine learning, data manipulation, big data, and cloud computing. Okay, now a little overview of the Bangladesh IT service sector. That is, the IT sector in Bangladesh can be categorized into software, internet service providers, telecommunications, call centers, and hardware sectors. The sector is growing rapidly over the years, and the market size of the IT sector is now about 1.4 billion USD. And the export earning is 1 billion USD. And it has a huge, pretty much huge, even though it's less than RMG exports, but it has a pretty much less than 1% of the share of GDP also. And the exports is increasing over the time, and the sector is trying to expand globally. That is, the local software enterprises are rapidly expanding, with local businesses contributing for 75%, whereas 25% is accounted for the foreign firms. the IT, let's talk about a little bit about the IT sector workforce. The workforce at present has there is already more than 4,500 software and IT organizations, which utilizes more than 3 lakh domestic IT experts, and roughly about 0.22 million IT professionals, of which 35,000 belong to the software industries, 30,000 belong to freelance software service, 50,000 belong to IT jobs in different non-government organizations and also other sectors. The employment is significant. The employment focus of 2021 are significantly higher than recent steady improvement. And most of the IT experts in typical programming firm are either developers or computer programmers are about 60%. Also, the majority of call centers and re-evaluating firms are BPO administrator or professionals, with just around 15% of their employees working with broad courses and other specialized areas of expertise. Next, if we talk about the IT education and trainings, there are over already 100 institutions, including universities, colleges, and institutes who provide IT qualifications. And every year, 10,000 or more, over 10,000 IT graduates each year. And there are approximately 300 training and education facilities that provide IT technologies and techniques. However, the IT industry looks to be falling behind in terms of attaining gender equity in the sector. What we have seen, according to some studies, that except for call centers, the proportion of female employees in most occupational classes is less than 20%. I would like to move on to the opportunities and challenges due to the 4IR emergence in the IT service sector. As there are opportunities, and we can also utilize them according to the opportunities. That is, in Bangladesh 2020, Bangladesh labor force participation was 55.7%, and the entire population has 14 to 60 ages from 14 to 64, that is 67.61%. So this group of people can be trained, can learn IT skills and knowledge through enrolling in IT-focused universities, colleges, and training centers, as well as on-the-job training or upskilling in while they are in the job. Also, for some IT jobs such as call centers and e-commerce, proficiency in English with minimum skills in computers are adequate for occupation. And from studies, we have found that 7 million English-speaking population are there in Bangladesh, which gives a little advantage to prepare for 4IR interventions. According to A2I 2020, we found that there are more than 10,000 new employment in IT and tech industries were to be created in Bangladesh, as enterprises invest in digitization of numerous services in response to work from home arrangements. If we go for the challenges, there are actually more challenges than opportunities, as Bangladesh first infrastructure, if we see according to the ICT indicators, according to technology access, Bangladesh still lags behind to our neighboring country India, and if we compare to USA, one of the developed countries, Bangladesh still lags behind in terms of fixed telephone subscriptions, household-owned computer, internet access, and international bandwidth per internet user. On the other hand, in addition, technology skills, in terms of technology skills, Bangladesh is, even though still at a neck and neck position with India, still it's lagging behind a bit. The mean years of schooling of Bangladesh is 6.2 years in 2019, percentage of gross secondary enrollment is 72.6% and 24% in tertiary gross enrollment. There are some other challenges I would like to address, that is due to the increasing possibility of human roles being replaced by new technological innovations, a lot of jobs are going to be redundant and obsolete, and qualification requirements for the new jobs will become more stringent and new skills and experience will be obligated. Upskilling and reskilling is nearly absent in the industry. According to the studies, 25% of the employees receives the training from companies' own training institutes. Labor skills are not at the requisite level, according to a lot of experts we talked to before, and the university's curriculum are disconnected from the market demands. That means that the curriculum does not prepare the students for the future industry experiences. The teaching method in Bangladesh is incapable of producing experts which meet market need, and IT graduates frequently find themselves unsuitable for job in the IT sector. Low investment in the high-tech sector is also a cause, and I would like to address this, that automation might and will increase gender discrimination. That is no effective gender sensitive policy in our country to upskill the women workforce. The policies we reviewed, which are formulated for the IT sector, there are many policies that are formulated directly for the IT sector, and there are policies that are indirectly for the IT sector. I'll discuss the latter one in a while, but there are around three policies and one vision for the skill development and job creation, and for the development of the workforce in Bangladesh, that is directly work for the IT sector. That is, first of all, there is Digital Bangladesh Vision, which says bring socio-economic changes through ICT and digital revolution across the country. National IT policy, which has objectives such as digital government, digital security, universal access to education, research and innovation, skill development and job creation, strengthening domestic capacity to cope with emerging technology changes. Next, that is National Telecommunications Policy 2018, that aims to ensure affordable and universally accessible communication, development of telecommunication market and services, efficiency and innovation, and local hardware standardization and local hardware and software production. And lastly, the direct impact, which has direct impact on IT sector, that is Broadband Policy 2019, which aims to ensure the easy accessibility to the internet through the up-to-date IT network and effective service delivery. I have also enlisted some policies that has indirectly impacted the IT sector. That is Industry Policy 2016, National Strategy for Artificial Intelligence. That is strategy which has 6 pillars of AI: are research and development, skilling and reskilling of AI workforce, data and digital infrastructure, funding and accelerating AI startups, and industrialization for AI technologies. National blockchain, and next there is National Blockchain Strategy Bangladesh, that recognizes the need to explore blockchain technology in order to advance its technical capacity, develop resilient infrastructure, increase efficiencies in e-governance, and foster innovations. Lastly, there is National Cybersecurity Strategy, which aims to work collaboratively home and abroad to manage all major cyber risks, creating a safe, secure and resilient critical national information infrastructure for our economy and society. I would say that these are indirectly impacting the IT sector as AI, blockchain, as my colleague will discuss later, that blockchain is majorly used in the health sector and AI similarly is used in every sectors. So this might also benefit the IT sector, IT service sector as well. So as we've talked previously for the whole in the whole presentation, that as there are more challenges than opportunities, the IT sector workforce may not be completely prepared for the 4IR intervention, and there might be a need for upskilling, reskilling in the future in the IT sector for the workforce. So for that we have come up with some recommendations. That is the focus required for developing and aligning the coursework and curriculum for engineering and polytechnic institutions with industry requirements. That is establishing interpersonal skills, instituting core technical skills, establishing psychological behavior to nurture the quality. Professionals must design a methodology that incorporates automation capabilities. That is, employees should develop their skill sets and acquire new ones in emerging technologies. Organizations need to develop a strategy for educating employees by engaging with companies to build workforce skills and knowledge. Organizations may establish innovative research and development centers to analyze and comprehend recent developments in global technology trends, forecast the industry's growing technology demand. Assist professionals in upskilling by establishing up-to-date training centers in-house within the nation. And lastly, IT entrepreneurship must be promoted through scholarship programs and sponsorships of training courses to develop its skills and foster a vibrant IT services industry with uplifting financial growth. Thank you.
Thank you, Nadia, for this presentation, for the presentation, and you have pointed out some of the challenges and also made some recommendations. So I guess our discussions will focus on some of the issues you have raised in presentation. Now I would like to request Mr. Soed Yusuf Sadat, who is a Senior Research Associate at the Center for Policy Dialogue. He will present on transforming Bangladesh's healthcare in the fourth industrial revolution. So over to you, Yusuf.
Thank you, ma'am, and good afternoon, ladies and gentlemen, and thank you all for making the time to attend our dialogue. It's really nice to see a very multidisciplinary group of people here in this room today. So today we'll be talking about the transforming Bangladesh's healthcare in the fourth industrial revolution. So this is part of our one of our papers on the future of work project that we are doing with our partner Friedrich Ebert Stiftung. So as some of you may know, this is the 50th year of Bangladesh's independence. So over the past 50 years, Bangladesh has made some decent progress on several indicators of health and macro indicators. For example, if you look at the prevalence of undernourishment or maybe life expectancy in 1971 was 47 years, and after 50 years it was like 72 years. So there has been some major improvements in macro indicators of health, and also in terms of mortality rates for mothers and for children, maternal mortality rate and also under 5 mortality rate, infant mortality rate, they have all fallen quite drastically over the years. And in fact, prior to COVID, we were almost on track to achieving these targets, SDG targets by 2030. But however, over the years, you see the Bangladesh's healthcare sector has been neglected in terms of allocation of resources, and we find that there was only one hospital bed for over 1,000 people in Bangladesh. But maybe this is expected because Bangladesh is a very highly populated country, seventh largest, most populated country in the world. But even in the health facilities that we had, we found that they don't have the basic equipment or the basic facilities to provide healthcare services, such as only 5% had ambulances, only 83% had paracetamol oral solution, 86% had thermometer, etc. So even the most basic equipment and facilities were not present in many of the healthcare facilities in Bangladesh. And there was only one registered physician for more than 1,500 people in Bangladesh, and that's also a matter for concern, especially in times of pandemics and epidemics. That might be a problem. And among the physicians, we see that there are different groups. So basically, in the healthcare facilities, we found that 28% have specialists and 59% had general practitioners. And we always have this small section on the health sector when we do our analysis of the national budget. And over there we always mention that the health budget in Bangladesh is not really all that big, and especially if over the last 2 years we've been going through a pandemic, but we find that the increase in the health budget even during these pandemic years was almost business as usual. There was no major increase in health allocation. And budget utilization for health has also fallen over the years. For example, if you look at fiscal year 2010, budget utilization was nearly 92%, but over the last 10 years, budget utilization in healthcare has fallen to only 74%. So maybe there is some kind of a governance issue there, because even if the budget is allocated for healthcare, it's not being used properly. And actual expenditure on healthcare actually fell during the pandemic years. And health budget as a share of GDP in Bangladesh is also very small, and it is less than 1%. Over the last 10-12 years it has been like this, and this is quite surprising, because in at least 30 other least developed countries in 2017 they spent more than 1% of their GDP on health, but we did not. So the problem is that when the government does not spend its money on healthcare, the people have to spend their own money on healthcare, and so out-of-pocket expenditure on health in Bangladesh is the highest in South Asia. Like it's more than 70% in Bangladesh, but it's the next highest country is India, which is around 60-something%. And also this is a problem because it's not only the highest in South Asia, but over time it's also increasing. So people are having to pay for this, for the healthcare services that they want. And this is a serious problem because many people are pushed below the poverty line because they are not being able to afford healthcare services. And also the CPI of medical expenses has also increased recently, so that is another cause for concern. So during the fourth industrial revolution, we can expect that at least there will be 4 different kinds of disruptions in the healthcare system. First of all, the speed of care will increase. We will be able to get access and get doctors and healthcare professionals more easily because of telemedicine and other technologies. We will be able to manage illnesses better through our better use of data and our gathered experience. The role of patients will also change from time to time. We will see that because of Internet of Things and because of wearable devices which collect data, patients will be responsible for collecting their own data. We were also talking that people are now doing their own COVID tests. So the role of patients will also change from time to time, and the relationship between healthcare providers and the patients will also be expected to evolve over time. And so in this study, this is mainly an exploratory study. We want to see what is the level of use of technology in the healthcare sector of Bangladesh and identify some of the benefits and challenges of use of technology in healthcare. And we want to see if using technology in healthcare facilities, it improves health outcomes or not. And we also want to recommend some policies and solutions to using and more technology in healthcare and leveraging the fourth industrial revolution. So in order to look at the impact of technology on and information services on health outcomes, we analyzed the data from Bangladesh Health Facility Survey 2017. This is a nationally representative microdata of 1,600 healthcare facilities out of a sampling frame of more than 19,000 healthcare facilities. And it also includes data from more than 4,400 healthcare service providers. So they basically interview around up to 8 people from every facility that they go to. And based on this data, we wanted to see if the use of technology in healthcare facilities was improving health outcomes, because from our initial analysis we found that in healthcare facilities where they were using a computer or where they were connected to the internet, the health outcomes were better compared to other healthcare facilities where they were not using an internet or not using a computer. But obviously there's some problem of bias over there. So instead of looking at direct correlation, we use some other modeling methods, and the main variable of interest for us was the number of live discharges made in the last completed calendar month. So this is basically the number of patients who were admitted to the hospital and then discharged alive. And this was probably the only health outcome indicator that we could find from the health facility survey. And our treatment variables were the use of computer, so it's a dummy variable if the hospital has a computer or not, then the internet availability, then also the availability of a dedicated statistician or a dedicated person for managing health data, and finally training, which is the training on health management information systems. So we wanted to see if the availability of a computer or the access to the internet or the presence of a statistician or even training received by the staff, training on health management information systems received by the staff, whether these treatment variables had any impact on the outcome of the number of patients who were discharged alive. But we cannot compare this directly, because if we do that, we found that in general, hospitals where there was a computer, those hospitals were generally much bigger and they had more doctors, they provided more services, they had better medicines, they had better equipment. So we could not directly compare because they were like apples and oranges. So instead we used a propensity score matching model, and we matched hospitals which were almost largely similar in various key indicators. They were largely similar in almost all kinds of aspects, the exception being that one of them did have a computer, the other one did not. So the matching was done on a number of independent variables. This included the number of services, the number of client services provided by the hospital, the number of beds that the hospital had, the number of staff that was posted in the hospital, whether the hospital had an ambulance, the number of outpatient visits in the hospital, the types of equipment and infection control precautions that the hospital observed, the number of diagnostic tests which the hospital had, the number of medicines which the hospital had. So medicines was a sum of basically antibiotics, worm infestation medicines, non-communicable disease medicines, antifungal medicines, and all other kinds of things. So we added them all up, and the level of cleanliness of the hospitals, and finally the number of years of education completed by the health service providers in that hospital or health facility. So we matched the health facilities based on these variables, so that when we apply the treatment, they are being applied on hospitals which are largely similar in terms of these variables, so that we can isolate the effect of the treatment and see what is the outcome. So from there we found that on average, provided everything else is constant, in hospitals where there was a computer, the average number of live discharges per month was 1020. They had 1020 more live discharges per month compared to hospitals where there was no computer. Similarly, in hospitals which were connected to the internet, they had 213 more live discharges per month compared to hospitals which were not connected to the internet. And the presence of a dedicated person or dedicated statistician to manage the data, in hospitals which had that, we found that they had 366 more live discharges per month compared to hospitals which did not have that. And this is between hospitals which are otherwise matched on several other key categories, key variables. So this was our main result from the empirical exercise. So based on this, we found that the use of technology does seem to have a beneficial effect on health outcomes, and so we wanted to propose a number of solutions for using technology in a broad scale. And the first solution we wanted to propose was a blockchain-based electronic health record system for Bangladesh. As you know, Bangladesh does not have any universal electronic health record system which is interoperable among the health facilities. So we wanted to take this opportunity and to use the latest technology, which is blockchain technology, to build an electronic health records database and to have a unique patient identifier for each patient. And this kind of a blockchain-based electronic health record will basically have, it will represent, each block will represent the data ownership and the data viewership. So on the one side you will have the data owners who will be the patients, and on the other side you will have the data viewers who will be the health facilities, healthcare service providers, pharmacies, health research institutes, etc. But the ownership of the data will be with the patients. And because this is a blockchain-based universal health record system, it will be decentralized and it will be publicly available, but all the data will be anonymized, so the patient's privacy will be protected. And the viewers of the data will not be able to see the identifying details of the patient, but they will be able to see the numbers. So they will be able to tell how many patients received ivermectin for COVID-19, but they won't be able to say who were these people who took ivermectin for COVID-19. So that is going to be there. And obviously blockchain will offer a large number of, will be able to offer a large number of services. It will increase interoperability of health data among different healthcare facilities. Right now we see that some hospitals have their own databases, but they are not interoperable. Sometimes they store data in one way, other hospitals are storing data in another way, so it is not very useful. And the problem is that most of these hospitals are using centralized database systems which are very legacy based systems and which have a single point of failure. So if one of their main computers or servers are hacked or if they fail, then the whole database will be destroyed or something. But in the case of blockchain, we don't have a single point of failure. It is distributed, decentralized, so that is more secure. And the blockchain will also allow us to create a data which will be effective for designing population level healthcare strategies, and we will be able to better predict and better map epidemics and pandemics like COVID-19. And also, once this electronic health record system is in place, we will be also be able to use this for healthcare bills and financial transactions. Often we find that in Bangladesh, the patients are dissatisfied that they were paying more money than what they wanted to pay, or maybe they feel that they were cheated. So these kinds of problems will not be there because there will be transparency, financial transparency in healthcare, and we will be able to include the pharmacies in this as well. And so the over-the-counter selling of pharmaceutical drugs, this will reduce, and so patients will be able to only take the drugs which have been prescribed to them. They won't be able to self-prescribe and take all kinds of drugs. And the transparency will increase because overall the patients will have access to their data in real time and in all the time and from everywhere they want. And we will also be able to use this in other applications like, to check the authenticity of clinical trials. We sometimes hear that some COVID vaccines were pushed through because of emergency use, but the trials were not all that good. We can also detect if there are any kind of complications from the use of various kinds of medicines. Sometimes we use 10 different kinds of medicines together and there's some drug interaction and we have some problem. And also we can even connect organ donors with organ recipients because of the database. So there will be many services that we can get out of this. And this will be a foundational technology which will allow us to leverage and use other technologies. So the benefits of blockchain are many. Obviously the data integrity will be there, and every entry in the blockchain will be authenticated with cryptographic proof, and so there will be no chance of any kind of false records or fake reports like fake COVID reports that we had last year. So nothing like that will be there anymore. The privacy and anonymity will be ensured, so no patient's identifying details will be revealed, and and only the numbers will come out, but the patients themselves will remain anonymous and private, and only if the patients provide their private key to the blockchain, then only the healthcare provider will be able to understand who that person is. Before that, it will not be possible. And the distribution will be across all the participants in the network. So if we can actually implement this in Bangladesh with the help of the government and international partners, then all the healthcare facilities will be part of this. So it will not be like the data is stored in only one place and only the large hospitals are using it. It will be there for everyone. And there will be a security from decentralization. That means that there will not be any single point of failure. So the data will be replicated all across the blockchain, and there will be no single point which can be hacked or attacked. Even if one server is down, the whole system will still be functional. And it will be transparent and accountable. Everyone will be able to see it. It's a distributed public ledger. Anyone will be able to see what's going on. So it will be like the stock market. You can see the trading going on, but you don't know who is buying, who is selling. So it's going to be like that. The health data, you will see that people are receiving ivermectin or people are getting infected with COVID, but you won't be able to know who is receiving the drugs or who is getting infected. And the data will be auditable because in a blockchain, the entire chain of data is always there. So anytime if you want to go back in time and audit the data and see which kind of drugs were used, what diseases were there, you can go back and analyze that data. But the challenges are many. We will only mention a few. First of all, there's the initial high cost of deploying this kind of technology. But for Bangladesh, I think the good thing is that since we don't have any kind of electronic health records, so this is an opportunity for us in a way, because we don't have anything, so we can start with the latest technology. But for other countries which already have some kind of electronic health record system, they have to dismantle that and then adopt blockchain. So that is harder for them. Blockchain will obviously consume a lot of electricity because from Bitcoin mining, in many countries actually this is why Bitcoin mining is not allowed, because it consumes a lot of electricity. And also the limitation will be there on the size and type of data that can be stored on blockchain, because blockchain was initially a technology made for financial transactions in Bitcoin and other kinds of cryptocurrencies. So inside a block, it's more suitable to store small and discrete amounts of data like financial transactions. But medical data is like big data. It is very high in volume. It has lots of variety, and it is high velocity data. So the problem is that you cannot store medical diagnostics imaging inside the blocks. So if you want to keep the X-rays and PET CT scans and MRIs in the blocks, that will be difficult. So you will have to keep it somewhere else. So there will be some challenges. And so this is our idea on blockchain, and if we can implement the blockchain, it will be a foundation for other kinds of technologies, for example machine learning. And with the data that we have in our blockchain, we will be able to implement lots of new and improved machine learning algorithms which will be able to predict disease before the onslaught of illness. They will be able to design effective strategies for preventive healthcare. So many of our experts are here, so I will not explain what machine learning is, but basically what it happens is that traditionally in a computer program, we are giving the computer instructions, and then the computer, based on the instructions, it gives its output. But in machine learning, the computer learns from experience, just like humans learn from experience. So when we provide data and the computer analyzes that data and it gets better the more data we give it. So with machine learning, what will be the advantage is that a machine learning algorithm can be fed with millions of instances of training data, whereas a doctor, even if they're doing practice for 50 years or 100 years, they won't be able to see so many patients in their lifetime. So the algorithm will have more experience than the doctor. So the accuracy of the diagnosis will improve, and also we can predict, with unsupervised learning, we can predict new patterns, we can detect outliers, we can classify people according to their health characteristics. So this will be good, and especially I want to emphasize, especially for a developing country like Bangladesh, we need to focus more on preventive healthcare, because you see curative healthcare is very expensive and it's very capital intensive, and for us, a country like Bangladesh, we need more preventive healthcare so that diseases are prevented before they occur rather than they are treated after they occur. machine learning will help us with that, and it will be useful if we use it in conjunction with other scientific studies. The challenge, however, is that we don't have the kind of data to use this kind of algorithm at this point. That is why we mentioned the blockchain database in the first place. And obviously, machine learning algorithms will be only as good as the data that they're given. So that is another problem for us. The other solution that we are proposing is the home hospital, which is a radical new platform for healthcare. And we feel that the hospital of the future will be in your home. So patients who are normally expected to stay in a hospital, they will be able to stay at home. They will use a mobile application, a location-based mobile application that will connect them to the hospitals in their neighborhood. And using that mobile application, and if we have our blockchain-based electronic health records, all the health records will come into that mobile application. They will be able to get services from all the hospitals in the neighborhood, just like they would if they went to a regular hospital. But instead of being admitted into the cabin of a hospital, they will stay at home. The nurses will come and visit them. The duty doctors will come and visit them. If required, they will bring in small equipment. If required, they will do some testing. So the home can be your own cabin. It can be a hospital for as long as you want. This is especially very useful for patients who are elderly patients, who have chronic diseases, who live in urban areas, and who need prolonged treatment, which can be very expensive in hospitals if you stay there for so long. So, and this will obviously have several other benefits. It will reduce the risk of patients getting hospital-acquired infections and illnesses. Also, they will save their time. They don't have to go back and forth from the hospital and come back home. And the burden on the hospitals will be lowered in cases of epidemics and pandemics. We will not have these chronic patients crowding the hospitals. And the home hospital will also create a lot of employment, because if we want to launch it and if we really think that this will work, then we will need a lot more nurses, we will need a lot more doctors, we will need a lot more medical staff to be able to provide these services. So it will create employment. And for hospitals themselves also, it will bring the hospitals together, and they will be able to reach out to a market which they previously could not get into, because many people don't want to go to the hospital, they don't want to go to the doctor because of high out-of-pocket expenditure. They think that if they go to the doctor, they will become poor, so it's better to stay home and be a bit sick. That's better. So the hospitals will be able to reach out to those patients who feel that they can't afford hospital care, but they can stay at home now and they can get this hospital care for much lower price. But the challenge is that we don't have, again, the problem is that we don't have any interoperable patient data, and also starting a third-party home hospital digital platform might be challenging in terms of legal and regulatory issues, because such a company would not be, classified as a hospital. It would not be classified as e-commerce. It will be something which doesn't actually exist. So it will be very hard to make any policies for it. It will be hard to regulate such a company. And also, initially, large, big hospitals may be reluctant to join this kind of a network because they might feel that they're well off on their own. And also, the quality of services, healthcare services provided at home will be hard to monitor, and the quality will be hard to maintain even. And we might see that, the healthcare service providers are starting to provide services outside of the platform, so they will just simply not use the application, they will just provide services one-on-one, and that can be dangerous. And so there are some challenges, and obviously we don't have that kind of high-speed internet to take it to the rural areas, and the hospitals and the healthcare facilities in Bangladesh are not homogeneously distributed all across the country. So this won't be effective if you don't have a hospital around your house. So finally, I would like to say that obviously the fourth industrial revolution is having a big impact on the healthcare sector, and it is generally considered so for most countries and also for Bangladesh. We feel that although Bangladesh is lagging behind in some indicators of technological progress, but the time is the right time is right now to act on this and to implement the technologies of 4-hour to improve the healthcare outcomes for Bangladesh. And from Bangladesh's perspective, implementing 4-hour technologies will require a lot of investment. So this investment needs to come from the government, from the private sector, and also from the international development partners, especially if we want to implement foundational technologies like blockchain. We need some initial investment from the government to get things started, and also for maintaining the blockchain, because the blockchain will not, in some other countries like in Estonia and other countries, they have used this, but the problem is that it is not always commercially feasible to keep it running. So there has to be some kind of a business incentive for the companies to be into this blockchain, and the government also has to subsidize that. But ultimately, without investment in the healthcare sector, we don't feel that the targets under SDG 3 will be achieved by 2020. So that is very important. And from this study, we found that the use of technology and information services did appear to improve health outcomes in healthcare facilities. And from our propensity score model, we saw that the average number of life discharges per month was higher in health facilities where a computer or an internet connection or a dedicated statistician was available compared to health facilities where these facilities were not available. So that is about it. And so in light of these findings, we came up with three main propositions. The first one being that we would love to propose a blockchain-based electronic health records database for Bangladesh, with each patient having a unique patient identifier. The second, once we have such a database, we could start using it for machine learning algorithms. And finally, we could also explore location-based mobile applications for home hospitals. So thank you everyone, and we'll talk.
Thank you very much, Yusuf, for this presentation. So I would now open the floor. We have a number of designated discussants. So we have really very competent and very specialized experts. So I would like to call upon the distinguished panelists. So you can focus on both the topics which we have presented or any of them. So first of all, I would like to call upon Dr. Muhammad Abdul Razak, Professor, Department of Computer Science and Engineering, University of Dhaka. So আপনাকে এখানে আসার জন্য ধন্যবাদ, এবং আপনি যদি ইনিশিয়াল বক্তব্য শুরু করেন।
Thank you, Samida. It's my pleasure to be here and to learn a lot from the presentations. Thank you very much, Nadia and Yusuf Sadat, for your nice presentations. And I also appreciate the effort taken by CPD and FES jointly for discussing on such an emerging topic. Well, I myself have been in touch with working related to different cutting-edge technologies of fourth industrial revolution for about 2 decades. I have been actively working for the development of efficient technologies related to Internet of Things, cloud computing, and related areas that touch medical sector as well. Well, 3 years back from now, I also initiated one international conference in Bangladesh focusing on fourth industrial revolution, namely International Conference on Sustainable Technologies for Industry 4.0. So in that connection, I do have some experiences. So I would like to start with my practical experiences in the field of medical sector. One of my classroom teacher in South Korea, aged 87, somewhat around in 2008. He was in an elderly home, and he was in monitoring under the surveillance of different sensor systems and activity recognition systems. And one evening he felt bad, and it was detected within second by the central system, and ER ambulance reached his building within 5 minutes and took him away for the further treatment. And thereafter he lived for longer period of time, and it was a national it got a national media coverage because he was the inventor of light emitting the LED monitors in Samsung. So in developed countries, the health sector has got special attention in developing the different cutting edge technologies. What Yusuf was presenting, a national health record database, but that is also present in many other countries. When I took my kids, small kids, to my family doctor, all the reports were there. Some 2 months later, when I brought them for another treatment to another hospital, I saw that they have all the records, previous records, what are the medicines, what are the diagnostic reports, etc. were available over there, and the privacy was maintained. If the current blockchain technology is used, definitely it is possible to keep it more efficient, keeping the privacy. Well, I had some experiences working with body sensor network that basically encompasses different sensing devices across the different parts of human health that can continuously monitor different physiological parameters and be connected with the doctor. I had another experience that is also in South Korea. One of my friend's father is 82 or 83 at that time. In one day, a doctor called my friend at around 4:30 a.m. in the morning. What happened? Even the nurse in that room did not notice the current condition of the patient. It's electronic sensing and other devices that notice the severity, and the data is sent to the central server, and it is being processed, and the doctor is connected with his mobile application with all the patients, and doctor received a phone call from the server system at that time, and from there he sent a phone call to us to be there, rushed there. Well, unfortunate thing is that that patient died in the early morning. Anyway, the thing is that if we be able to make sure the utilization of the cutting edge technologies, definitely there is ample scope of increasing the quality of human life, and we are basically far away from that state of the art situation. Even whether a patient is taking medicines according to the prescribed advices of the physician can be monitored. I mean, you can take a capsule that will take care of your the disease. At the same time, a very tiny sensing component will be over there that will monitor what are the medicines have been taken by that patient and will be sent to the server system, so that whether the patients are taking medicines timely, that can also be monitored. So we call it e-capsule, that can be thought of. So the state of the art is very advanced. My question is that whether we can take the advantages or not. Well, this is a long topic to discuss, and we have a good number of discussants. In short, I would like to focus on I think we need some sense of perception. As in education. In Bangladesh, we have only very small, somewhat around 2 or less than 2 of the GDP is being invested in education, which is very less, and that is causing rapid brain drain, that is causing no appreciation for even quality teaching, learning, and research, and in Bangladesh, the industrial investment in research and development is also insignificant. So that is another important lack we do have, and the opportunity we do have is the plenty of human brain, and I should say that we do have intelligent young people. We need to make them really knowledgeable and skillful in a planned way, and that can definitely help us to make our young generation be ready technologically, so that they can take different innovative and creative ideas and develop the different solutions. Well, in our country, the education system is still traditional. The skill-based workplace skill requirement need to be further analyzed. That is rapidly changing, and fourth industrial revolution is popularizing a spirit that is VUCA. In short, V stands for volatility, U stands for uncertainty, C stands for complexity, and A stands for ambiguity. Let me explain a bit. Volatility refers to the fourth industrial revolution. Its technological aspect, its circumference of the circle is gradually changing, and I mean every time we need to be updated with the new technologies, and the persistence of a single technology is not longer. So many new technologies are converging together. I mean, someone achieved a particular technology, there is no reason to feel that, well, he or that community or that learning is adequate for solving a particular problem. So every time it is changing. Uncertainty is there because many people are not able to undergo with sufficient training, workshop, or knowledge development, and their job is really becoming they are in a state or uncertain. Well, complexity due to the synergies of different technologies in a particular platform, complexity is also increasing day by day. So that is another important point to consider, and definitely ambiguity is there because there are different perceptions from different corners of the people, and a good number of people are in a state that whether they will adopt for industrial revolution technologies or not, they are not sure about, and what are the benefits, and whether they are really financially viable or not viable, they can judge, and there are different levels of debates over there. So making it short, I would like to say that the global competition is increasing. The jobless competition is also increasing because job methods are being customized, and we have to think about developing a very skilled, knowledgeable society first to address all the other challenges that are coming ahead of us. If to learn from their experiences. And but that's all from my side at this stage. I may take part in some other discussions related to national policy framework in later part. Thank you.
Thank you very much, Dr. Abdul Razak, for those valuable comments. You have shed light on a number of issues, mainly focusing on the healthcare system, so how we can upgrade with the help of technology. So I would like to request now Professor Syed Akhtar Hussain, who is a professor and head of the Department of Computer Science and Engineering, University of Liberal Arts, Bangladesh. So in the interest of time, I would like to request if you can confine your comments within 7 minutes, then we can come back in the second round. So we have ample time then to make further comments. Over to you.
Thank you very much, Famidapa. It was very nice session, both the papers. I was really a little bit, I went through the papers while I was traveling all the way from Dhanmondi to here. So both the papers are wonderful in terms of its content, the data. And I will request that if you can take it further as a country paper and make it in a top tier journals, because what happens in Bangladesh right now, we are more focused in terms of building up our research capacity, and if this paper may go through some review process, may add serious value not only for universities but also for the industry. So that is my first comment on the paper, because I looked at it from the review point of view and I saw that some literatures could be further reviewed to improve this paper to a very high quality paper, impact paper. That's first. The second thing I just want to add, because I'm connected to many government projects, and at the moment I'm actually working very closely with A2I, so I'll put you into some stats before I talk about the other two presentations, wonderful presentations made by Syed Yusuf Sadat and Nadia Norin. It was a very good presentation. First of all, A2I right now actually into movement of e-governance, and there are about 2,400 services, G2C services. They say plus is something about 2,400 or close to 2,500 services. But about 1,000 services got digitized, and for IR inclusion is about only 25 plus services, and there are 50 plus services in the progress of inclusion of fourth industrial revolution. So you can understand we are at very much at the infancy. We are just walking through this fourth industrial revolution tier, whatever we call it. But I have a question to Syed Yusuf Sadat. While you were presenting, I had a question came in my mind, is that you actually had a chance to see 1,600 healthcare service providers. What is the percentage of that 1,600 are serving fourth industrial revolution kind of thing? That is one. But second is, you came across 5,400 professionals, the service providers. What percentage is having a knowledge on fourth industrial revolution? And that's the question. I will definitely get the answer. I will request, I will just be very brief, because the subject is very close to our heart, and we are right now developing a blockchain solution for University Grants Commission, because in Bangladesh we have a problem of identifying and validating certificates. And UGC suffers a lot, because a lot of certificates they receive from the Western world that comes to the UGC for confirming that the certificate is not fake. And it goes back and forth across the universities, because UGC is communicating to university is communicating to UGC, so is a kind of time-consuming process. So we are developing a blockchain solution with the support from the government. But while I was working in the team, I am leading the project, so I understand the constraint is only you have to have a brevity to start something without thinking much of what you have and what you don't. That's one thing. That means I'm talking about a I'm talking about leapfrog, kind of thing, that I don't know anything that I'm doing. Right now, we are actually creating business processes for the universities so that university can really have this maker-checker process of validating a certificate using blockchain, creating a hash code, making an understanding. The, the most important thing missing is in the entire process is education. I'm not talking about education in the university, I'm talking about education of the enterprise. Education in the government. We are actually working in that area, how to educate agency to understand how to take the leverage of fourth industrial revolution. So I will just conclude by saying one thing, that I'm very happy that you invited. I'm very happy to meet my colleagues, Professor Rajab and all my colleagues here, industry colleagues, and we're very, very close. That becomes a very good meeting place. At least come out of the box and come into much better place than to think further. I will suggest that CPD can have a wonderful collaboration with the universities to foster this research to something very meaningful, because you can have partnership with the universities, and universities are right now in a challenge situation. Let me tell you why. Because there are international ranking. Every university is having a very serious drive that how to enhance research, because you are not in the international ranking, you are not getting enough students, quality students we are talking about. So CPD can have a wonderful collaboration for research with the university, number one. Number two, if you are so tempted, I will say, in Bangladesh, I'm a kind of burning fingers. I burn my fingers. I try things and I understand that what is to be done. You can actually have a fourth industrial revolution Olympiad hosted by CPD and many university industry together. And I'm very happy that this is a session where we are from academia, industry, and a very important partner is CPD, because you work on the policy, you have a very well tracked records, because I know of CPD since its birth. And when David Priyada was with CPD and driving. So with this, I appreciate this thoughts. The paper is wonderful, and perhaps it can reach to the international ranking. Thank you so much.
Thank you very much, Professor Hussain. Indeed, we are, willing to collaborate with, universities, and we always look for intellectuals also. The CPD is a think tank, and the role of think tank is to advocate policies. But then, in order to have an effective advocacy of policies, you need to have solid research, evidence-based, analytically rigorous research. And I think universities are well placed to do that research. And as you can see, that this is not a typical CPD dialogue. Usually what happens that, in a typical CPD dialogue, there will be ministers and policymakers, a lot of media, and then the focus. But we intentionally wanted to have this very exclusive session with the experts, so that we have a solid discussion amongst ourselves, and then we can improve upon the paper, and we can also learn. Then maybe at one point in time we will have a larger policy advocacy session. So, but we are still at the infancy level, so as you have mentioned. Thank you very much for pointing out those. Now I would like to request Professor Sadrad Hussain, who is also a computer engineer. Yes? But
it can be, some industry, then academic.
Oh, okay. Yes, okay. I have the three names, then I was going to change it. But okay, if you want to come in, you can come in. But I thought, I would then... He has to come in. No, I wanted to also give a chance to a lady, female colleague. Then, yes, so then I'll come to you, Manzoor bhai. So, Dr. Shagufa Anwar, who is the former Director of Communication at the United Hospital, with a lot of experiences. Previously, she was also at the then Apollo Hospital, now Evercare. So she deals with day-to-day issues. Please.
Yeah. Thank you, Bobby. It's a pleasure to be a part of this exercise, I would say. And as I was doing the telephone interview with Mr. Sadat. That time, actually, I felt from the questions that I was having from him and the interaction that we had over phone, I could feel that this is going to be something very timely endeavor that our healthcare needed from way back. The need was actually there, but the need was not being surfaced as it was. But COVID, I would say, the pandemic has actually forced it upon us, and the resistance that we had, the resistance to change, from the conventional method of providing treatment and the service to the patients, and that actually had lots of change, especially from the healthcare providers. This change was actually brought upon them by the pandemic. The situation actually forced the change on them. So that is one silver lining that we have from the pandemic, I would say. So the two presentations that we saw, yes, as others have said, very impressive, I must say, and very insightful. But the thing is, as I have seen from my own experience and from my own practice, is a system is only as good as the data input. Unless and until we give input of the right data at the right time by the right person, no system is going to serve us and no information we are going to get from the data. So I have seen from my experience of working in hospitals for more than 2 decades that we have lots of data. We are actually data rich, but we are very poor in information. Data rich, information poor. DRIP syndrome. That's what we are suffering from. So the main reason is the data that we are having in our hand, we cannot convert them into the information because the way that this data are being taken in the system are not in a form which can actually be used as a tool to generate informations. So in the 50 years of independence that we have in our country, and also having a pandemic for last 2 years, the huge amount of information that we have in our country, and looking back even from today, the amount of data that we have and the kind of research, the kind of I would say prospective and also retrospective research that we could do with the data that we have in our hand. We haven't done even 1,000 part of it. We haven't done. So many things are there which are absolutely independently, individually unique for Bangladesh, which we could not deliver, which we could not roll forward, which we could not bring into the eyes of the globe to have a look at. Because the data is there, but we could not, bring the information from out of those. So I have ICDTRB here. They're the one of the torch bearers doing the research and other things. But I would say that is also kind of an independent and insular type of research that they have done. So the research that they have done in the field of diarrhea or in other cases, if you want to compare that with other centers of the country, maybe from other public or private centers of the country, you won't have any comparative data. So that goes to show that we do have a need of a national and central platform, which actually came out in Sadat's presentation. So whatever we have so far is independent and individual and specific center-based initialized endeavor. So we need to have a central platform where everybody will need to give the input of some basic information so that given the time, given the need, if we need to ascertain certain data for the sake of the community, for the sake of the nation, we would be able to get that from that central data, be it government, be it any private sector, be it CPT or anyone. So that is very important. We don't have that. So when we talk about national registry, it's not about any specific disease. You ask about heart disease, any national registry we don't have. You ask about cancer, any national registry we don't have. So, we have some center-based data, maybe, 4 or 5 or 6 multi-center data, and we make a going forward assumption from that, and then we come to a figure. We do not have any actual data. So this needs to be done not only for disease specific, but also to have, as Sadat has said, inter-central different, to have interoperability between different centers, so that the patient would be in a position to compare his or his family's own health status center to center. It wouldn't be individual center based. So that is very important. So the blockchain based system that he has recommended, frankly speaking, I don't know whether that will work or not. But what appealed to me is the need, the benefits, that potential services that he has highlighted. Those are absolutely going to be essential. And the most I would say pleasant outcome of it is this is going to benefit the patient. Whatever is going to come out of it, whatever is the benefit of the whole exercise that we are going, we have started today from this discussion, also from the interviews earlier, the patient is going to be the ultimate beneficiary. At the end of the day today, what do we see? We are having so many, budget allocations or other things, but the patient at the end of the process, poor loser of the whole thing. So we need to think of the patient at the end of the day. So whatever research we do, whatever systems we do, whatever registry we do, patient needs to have. And I would actually dream of a day when each patient will have their own barcode. In each individual patient will have his or her own barcode, and with that barcode, he would have access to all his, information, all his investigation, everything at his fingertips. And he will be the sole custodian of his own information. If he wants to share it with any doctor in the country or outside the country, he would be able to do that. And that is so very important, and I believe that is doable as well. That's not very impossible to do. And another thing is that when we are talking about SDG or MDG parameters, and we are having a comparison like with other countries and our ranking and in terms of the South Asian countries, I believe from the policy point of view, we should actually, especially for healthcare, add another parameter there to the healthcare providers, and in terms of comparison between different countries, is how much access to technology the healthcare providers have. That should be another parameter. We are talking about maternal mortality rate, we are talking about infant mortality rate, we are talking about, access to vaccination, all these things. But access to technology, because all these things have come out, internet speed, we don't have computers, all these things. So if we sum it up in one basic point, that access to technology for healthcare providers across the countries should be another parameter that we should look at. And as we had the academicians here talking about, embracing technology at the nascent level, here another recommendation I would want CPD to take it forward is that when we are studying as medical students in medical college, and also in nursing institute, and also in the medical assistant training as we have, we should give this emphasis on, enabling them to have to be tech savvy, if not on a general basis, but on a specific customized basis, because that is what going to be the world going forward. So it's nowhere there now in the curriculum. So I believe that should be part of that, be it in medical school or in nursing institute or in other trainings. So that is another recommendation. So other than that, whatever has come forward here, in terms of continuity of patient care, in terms of patient information registry at a central platform, and also in terms of electronic medical health record, I believe the presentation shows us the right guideline, and I'm sure these has all come from the interviews and other thesis and other analysis that they have done to bring it out in the presentation. Because so far in our health sector, when we talk about 4IR, Do we really understand, the healthcare providers in the country, do we really know what it means, what it actually means, fourth industrial revolution? To us, now technology is limited to call center or to some extent hospital information system. Even, I would say, in 80 to 85% of the cases, if not more, hospital information system is only dependent on some input of patient data, not even friendly with device. There are, in more than 85% of the cases, we would see the investigations, the lab, all these informations are not actually getting into the HIS. HIS is mostly, encompassing the patient information. So device compatibility is very important when we are talking about AI. AI, artificial intelligence, would mostly focus on modern devices, and those devices will have to be compatible with the system. I can bet even the bigger hospitals that we have in this country, we can count those in fingers. More than 85% of the devices are not compatible with the system. So unless and until we have those data there and we are actually giving input manually into the system, getting the data from the device, there are always the chances of errors, and we do see that across the across the city. So these are the things that we need to get into. And another thing when we that I have seen here, we talked about home health therapy. Very important, I would say, need, as we have found in this, mostly in this pandemic time. So the legal issues are there, Sadat has highlighted, because these will be very sick patients. So when the healthcare providers are going to different homes and residences and providing service in the middle of the family members, and we know how volatile and how hostile our nation is generally. So when a doctor or nurse is going to somebody's home and giving service to that very sick patient, and suddenly the patient expires, because we have experience of that, even in hospital setting. So these legal aspects are there. This is very important, because I have had talk with many interested people who actually wanted to venture into this kind of services, but this is one single point for which they actually backed out from it. What protection we are going to get from that. So that is very important. That kind of framework would need to be there. And another thing which is sorely missing from our healthcare system is a step-down facility, which is absolutely available in the Western world, very popular in America, Canada, Australia. There are, between hospital and home, in between, there are step-down facilities. For example, my father gets admitted to the hospital in a critical condition, he gets better, now he gets discharged, and directly the patient comes home. And at home, the family members have no clue what diet to be given to him, how to manage him, what exercises to give to him. They look for, different healthcare providers, some relatives, someone comes, do this, do that. Sometimes doctors are telling something, half of the things are being untold. So in between, in all these modern countries, there are step-down nursing homes in between. So they are discharged from the hospital, go there, stay there. So they are low-cost, low-cost hospitals, because actual doctors are not there, therapists are there, nurses are there. Maybe the doctor is going and having a look at the patient for once a week, going there, and they stay there for 2-3 weeks, then they recover a little. After that, they come to the hospital, come to the home. So this is sorely missing in our country. And nobody is taking this initiative, but that is very much needed. Even the hospitals which are running, very well, they themselves can take initiatives, because I have seen in India, in Bangalore, the major hospitals, for example, NIMHANS, there is one hospital, National Institute of Mental Health and, the disabled. They take, under one hospital, there are 5 to 10, step-down facilities. So they themselves are referring patients from their hospital to those centers, and from that center, after 2 to 3 weeks of recovering, then they are going to home. That is missing in our country. Maybe in private level or in government level, we should take initiatives to start that. So these are the basic things that I have thought of as I was going through the discussions around. And one thing I think, Sadat, you could have brought into the presentation is the insurance. It is not there. the need for having a medical insurance. We talked about out-of-pocket expenses many times, and you are rightly, you have rightly pointed out it is increasing, but as long as we don't have small to medium to big level of medical insurance coming into practice, either by individual agencies or by international agencies or by hospitals themselves or from government initiatives, this is not going to decrease. It has to come down little with the help of insurance only. And last but not the least, very, very pleasantly, I have seen even in Nadia's presentation, it has come out, the gender issues has been highlighted. And I thank Famida Bharbi. I'm sure having a female leading CPD has brought that attention. I'm sure some amount of attention has come from that sensitivity. So it was really pleasant to see that angle, and I appreciate that. And with that, I'm going to finish my discussion. Thank you.
Thank you very much, Dr. Shagufta Anwar. Indeed, you have brought out a number of recommendations and also some of the challenges. And your last point regarding the insurance, which is absolutely so important, and actually pandemic has taught us that how important it is. For the well-off household, it's not a problem, but the problem is for the poor households, and that's why we recommended in each and every presentation we make on health, we one of our recommendations is that universal health insurance or universal health care. So these are the very important and important policy recommendations. But again, when we propose it to the government, always the issue of resource allocation, all these come up. So I think pandemic is a lesson that how we should go forward. That's a different discussion, but thank you for pointing out. And your point of regarding on the access to technology. So indeed, there is this SDG 9, which talks about access to ICT. And also it talks about that there should be a strive towards universal and affordable technology by 2020. So 2020 is past. Technology and internet. I don't think several countries in the world, not only in Bangladesh, I mean, we are way behind to reach that goal. So that's an unfulfilled agenda across the world. Thank you very much. Now I'd like to call upon Mr. Mohammad Manzoor Mahmood, who is the Director and Chief Operating Officer, Data Soft System Bangladesh Limited. মনজুর ভাই, আপনার কাছে আপনাকে ধন্যবাদ, আপনি আমাদের এক্সপার্ট গ্রুপ মিটিংয়েও ছিলেন, and you have provided অনেক important অনেক recommendations and insights. We have been benefited and we are going to benefit more today. Thank you.
অনেক ধন্যবাদ আজকে আমাকে এখানে ডাকার জন্য. Grateful to all of you. Two good papers have been presented. However, I'm not going to go into nitty-gritty of those papers. I have read both the papers and also took some notes on when presentations were given. I will today focus only in 4 aspects of it, which is basically commercialization aspect of it. We can do research all day long, we can talk about it all day long, we can do hundreds of seminars, but if it doesn't reach to the beneficiary, it really doesn't matter anymore. We as a nation, we're extremely bad at that. We talk a lot, do very little thing. Most of our things are actually lip services. We love to give ideas, but we never do that. However, I belong to a community where we have to do it. Software projects, either it works or it doesn't work. If it doesn't work, I never get paid. So as an orientation, we are in the doing kind of orientation and extremely accountable. Anything we do, if it doesn't work, it just doesn't work, and we as a company, we suffer. So fourth thing which I wanted to really bring into attention of everyone here is one is good that we talk about emerging technologies, 4 hours and everything. But there is something known in technology world which is known as right commercial adaptability. So I can, from my PhD thesis, I can tell, okay, a blockchain-based patient record is extremely well. It would solve me so many problems.
We already have solutions. Why aren't we looking at those solutions which is already available? Bangladesh did a chip-based national ID card. So almost everybody has got an ID card. People who are below the age, these days everybody is having a birth certificate, which is a 11 digit or 16 digit, which is a traceable thing. Why don't we start something with that? Second thing, a lot of people would look to government. Government would do this, government would do that. We need government support, we need nothing. We need to, as a nation, we need to be oriented that what is in for me. If tomorrow United Hospital knows, if I have a unified patient record, I have more patient then. If that is the thing, immediately you'll jump into that bandwagon. Okay, who can do this interface? If tomorrow a bunch of hospitals they says that our information of testing results can talk to each other, immediately you'll find devices which can let the interface come in and talk to each other. Yeah. Why this doesn't get done? I found that out. These are all lobbies. These are all interest groups. They will never let you happen this. They'll create this island of things, and we sitting over here will talk about it all day long. But they will never do it. I would really thank this government the way they have handled vaccination work. A nation of 16 crore the way with IT, they have handled this matter in a very critical time. Hats off to them. With such a little budget. Nobody talks about it. And going forward with these simple informations, we can do so much. Because we have so much information available about that person. Second thing which I wanted to tell is, so first thing which I talked about is the record. I believe that blockchain is not the solution. We already have something that's built on that. Second thing is anything, we talk about adaptation, it has to be commercially viable. There must be what is in for me. Only way government can do that if government comes out saying that we want a unified patient record for all the hospital operating, the big one. Tomorrow, if we can tell the government that no hospital is going to run, you cannot admit one patient unless and until it is given in XYZ format. It is, tomorrow it will kun fayakun, it will happen. But who is going to do this? Who is going to bell the cat? So belling the cat is very important. Third thing which I want to give you an example of what 4th Industrial Revolution can do. I have written to this gentleman and a lot of other people. We have come up with a smartphone based solution with Stanford University in the US. It is directly from their research lab, which can, in a cell phone, which can do this thing. People talk about it, we have already done it. It can give you all the blood pressure related things, sugar, ECG, pulse pressure, heart rate, respiratory things, oxygen saturation level, blood temperature, only with one device. And we are already running it as a test basis in. Yeah, there is an app also with sensors and everything. We did, and it has got a lot of artificial intelligence kind of thing. It's already been used. We have showcased that in Daffodil Polytechnic Institute, 4th floor. You can go and get a free test done. We have already tested about 200. In the US, we have done around 11,000 people record. Totally AI based, and this accuracy level is more than 98%. You as a doctor, hope you know what it means. So, 4th Industrial Revolution is already here. We just need to know as a nation how to embrace that. And again, some forward-looking hospitals need to come up saying that I have few patients, they are vulnerable patients, they can do their thing at home. As an organization, we'll keep record of everything and see in the dashboard. My vulnerable 200 patient, wherever they are, we can always see them. The last thing which I would really want to point out is in one of the papers, it was told that entrepreneurship through scholarship, which I really didn't get. Entrepreneurship doesn't happen in scholarship. It's a what do you call it? It's a trait. Entrepreneurship cannot be fostered through scholarship. I, as an entrepreneur, would really want to point this out. Looking at all my PR group entrepreneurs, there are two kind of entrepreneurs. One is pseudo entrepreneurs. When their fund is exhausted, they are also exhausted. Another time is like Kotchop. They will be there till they become successful.
But those who want to enter, access to finance, initial.
No, these are all fake excuses. There are some kind of people, they are in the twilight zone. They're in between. They're like sometimes the cricket, batsman, always half-hearted shot, there will be a catch. So they are never entrepreneurs. These are pseudo entrepreneurs. Forget them. So thank you all. Thank you very much.
Thank you. Thank you very much. Yes, very practical. Some of the very practical, suggestions and also insights from Mr. Munzur Mahmood, as usual. Now, I would like to request Dr. Sejuti Rahman. She is assistant professor at the Department of Robotics and I can't even I can't even pronounce mechatronics engineering. Faculty of Engineering and Technology, University of Dhaka. So, Dr. Sejuti, please, over to you.
Okay, so thank you for inviting me to this very informative and timely session. I really appreciate the effort of Nadia and Sadat. You come up with very nice findings and recommendations. I would like to discuss some of those later. But now I want to share two recent experiences while developing AI-based technology for healthcare sector of Bangladesh. The first was developing an automated detection approach to autism spectrum disorder with the help of AI and deep learning. I think you all know that autism is a severe neurodevelopmental disorder and it has no cure. So early detection is the crucial part. So now health professionals use it called DSM-5 guideline to detect autism, but the problem is that it requires autism expertise, the involvement of doctors, and it's costly, it's time consuming, and as it's a very observational based diagnostic system, so it's too subjective. So all over the globe, researchers are trying to come out with some automated system that can automatically detect autism using the cues that often used by the doctors. So in Bangladesh, we formed a team of researchers in our department to come up with some solution, because we are also concerned because the prevalence of autism is also rising in our country. And we got the ICT fund to conduct this research, but the main problem was with the data. Today, many of the researchers and Sadat also talked about data, and I experienced the same thing while conducting this research. My first step for the autism research was to collect data from autistic subjects. So as I'm not an autism expert, so I wanted to collaborate with some health professionals, with some doctors who are dealing with the autistic children, and I was happy to see that the doctors are really, they had the strong desire to embrace this new technology. But I was shocked when I faced the institutional review board to collect the data. It's a procedure. When we need to collect some medical data, we need to get the approval from the institutional board. So when I was presenting my proposal to the institutional board, I couldn't connect with them. They didn't know words like neural network, and they really don't know what AI can do and what the associated risks. They were so scared about their subjects, their patients' safety, and data privacy, and so we got a big no from that side. We were shocked, we were really shocked, because we already got the fund from the ICT ministry and we had to run the project anyhow, but we don't have the data, and without data we can't do it, because as you know, deep learning needs a huge amount of data. So what we did, we thoroughly revised our methodology. Our initial plan was tracking autistic subjects' repetitive behavior and unusual gait pattern, but we decided not to go on this way because that requires a complicated experimental setup, and the IRB board didn't approve that. So we thought about a simpler method that just detects the unusual gaze pattern. As you know, our visual attention is triggered by cognitive process. So the gaze pattern is very much different from a typically developed child. When we show an image to a typically developed child, he puts his attention on center part or some salient features of the image. But if I show the same image to an autistic child, his gaze pattern and his saliency is totally different. So we thought we can use it, because in that setup we just need a child to sit in front of a computer monitor. We will just show him several images and then we will track his gait pattern and it's done. I will train the machine to look for unusual gaze pattern and detect autism. This time we were lucky. The IRB board approved our proposal, but we faced even harder challenge to get consent from the parents of the autistic children. They didn't at all let their children to take part in the process. But what we can do then? Luckily, we got an international data set of autistic child. That was released for all researchers, and we used that. We developed our methodology. We got our paper accepted in Cognitive Computation. That's a Q1 journal. And we also presented our paper in some international conferences. We were happy that we got some achievement. But we could have been happier if we could have developed the methodology for our local people. Because we use our government's money, we used our brain, but we developed the methodology based on foreign data set. So I'm not confident if that data will work for our children. So that's really shocking experience for me. And I would like to share another experience that's also, I hope I'm not making you bored with these research stories. I'm a researcher, so that's, I can. Okay.
We're enjoying it, honestly.
Okay, thank you. Okay, so it's actually another research project, and it's also related to AI in health sector. It was developing robotherapist that can guide post-stroke survivors in rehabilitation exercise and also assess their performance like a human doctor would do. And this time, this project actually was initiated by doctors. They actually came and asked for our help because they were experiencing a problem. As you know, a post-stroke survivor has to take repetitive therapeutic physical rehabilitation sessions over the life. It's the only treatment. But in our country, it's not possible always to do with the presence of a doctor or a physiotherapist because of the limited availability of physicians. So in-home rehabilitation is most widely used in our country, where the patients are prescribed exercises by doctors and they do these exercises in home. But the main problem here is when they do the exercises at home, there is nobody to monitor and observe and give him feedback. So another problem was in the doctor's side. When the patient came for the follow-up session, the doctor has no clue what he has done at home. So, he is just guessing and giving him prescription in that session. So the doctors actually wanted us to do something to mitigate this gap, and what we did is we developed a robotherapies that it's a software. It can be installed in a mobile, and a patient can take it home, and while he do his exercise, he can turn on the camera. It will record, and it can give him the performance score. You got 6 out of 10 in this exercise, and it can also show him some guidance. These are your wrong postures, you have to do this kind of things. And we also got this paper accepted in a Q1 journal. This time, I was smarter due to my previous experience. From the very beginning, I just searched for foreign data set. I never tried to go and collect for local data. So now the project is almost done. We came up with a very good software, but unfortunately, this time again, I can't use it for our local people because the exercise varies from region to region, and our doctor gives scoring in a totally different way. So again, our money is spent, our brain is utilized, but we made the technology for others. So that's my two.
The moral of the story is that we don't have data, we are using foreign data. It's not very suitable probably.
Yes. We are data rich, as ma'am said, we are data rich, but we are not information rich because we are not at all willing to open this data even for research purpose.
Just, sorry, one second. Just one question. So when you say the doctors went to you and they were actually asking for this, so are you open to receive suggestions? Are you from because you are in Dhaka University, right?
Yes.
And I didn't have any idea that a department like that even exists, That must be very backdated, Our idea of Dhaka.
It's a new department actually.
Back to 50s.
So, and not being connected to Dhaka University, for so long, not have, who are, the newer generations and all. So having that department, are you open to suggestions from others?
Yes.
Like this kind of things are needed for our country.
Yes.
So do you receive that?
Yes, sure.
Okay.
Yes.
So not on an individual level, you receive that from the departmental level, right?
Yes.
So officially you are open to receiving
Yes.
suggestions. So if someone is actually approaching you seeking some help, whether you can form some device or find out some findings and all. So there is a process, right?
Yes.
There has to be a certain kind of population size and how important it is for the population. It cannot be just some rare disease or something. It has to be a certain amount of population demanding this kind of service. There is a system, right?
Yes. Yeah. We will be more
Another
than
small,
happy.
another question from my side. Query, not this question.
You're cross-questioning.
Being a doctor, because she has done a great job, I should congratulate you, because artificial intelligence, use of artificial in the healthcare is really very demanding, and a lot of countries are doing that. We are lag behind from that aspect. So you have done two research, this is very good. But before the research design, have you, as Dr. Shagufas from the CLU, have you discussed this thing with the stakeholders, like awareness session, knowledge sharing, so that you have to break the barrier. Ice-breaking session should be happen. Now, people will not, in Bangladesh, people will not come forward, because these the two things you have mentioned is very highly delicate, like autism and this physiotherapy. So it is individualized also. So you need to break the ice of the people minds. Then you will get the support, because the research you have done, the outcome, that will not helpful the people of the Bangladesh, because it has done from the data derived from the other sources. So thank you, but I appreciate your hard effort. Thank you.
And also I feel sorry when you say that you couldn't break through that. I immediately my reaction was, I wish she came to me.
Okay.
Because I know these two things are so sensitive, and I have personal experience.
Okay.
Within my own family, I said, I wish I would have taken her to places, I would have taken her to different lands. So that means it was not enough, it didn't reach.
Ideally you shouldn't take somebody. There should be the system in place. Think about the people who are sitting there in the ethics board. You need to actually build their capacity and sensitivity towards this type. So
But that sense of loss, she was there struggling with all these things, and
No, but
we
it's one thing. On the other hand, she developed an experience. Have you noticed the second case?
Yeah.
She had a
She didn't even
greater
try
understanding.
for that.
Yeah. So that's actually added
But
as an experience.
coming back, Manzoor Bhai has said that education, when you talk about education, not only of students,
Yes,
but also
yes,
at
yes.
the enterprise level,
Absolutely.
government and the
Thank you very much, Dr. Sejuti. I think, we are discussing at the patient level. I would just, step back a bit and, go back to the root of that, research at the back, what kind of research is, happening and what kind of challenges your doctor or the scientists are facing. I will, so obviously going to Dr. Wasif Ali Khan, who is a scientist at the International Center for Diarrheal Disease Research, Bangladesh. So you do a lot of research, but in your research, I mean, how do you use the fourth industrial revolution, or what potential do you see there?
Okay, thank you, Famida. First of all, Assalamu alaikum and good afternoon. So I'm Wasif, basically a physician by training, but almost last 3 decades doing research, basically clinical trials. So I will, as I was, the 2 presentation by Yusuf, Sadat and Nadia Naurini was excellent. And as I was hearing this presentation, it seems like many of these things, actually, as Sagusta mentioned, we in a silo, we do all sorts of data collection. It's always been going on in ICDDRB. In fact, in ICDDRB from 2010 onwards, we have a hospital in Dhaka. We have stopped paperless data. Any patient coming, screening, and during the hospital, this everything on tablets. This has been started, and you can imagine about 200,000 patients a year that's coming. So we have from last 10, 11, since 2010, I think 9 or 10. So what is the advantage of this? As it's been spoken by many of you, that obviously this, because we do research, so we get a lot of new ideas, things of that, like lab data, clinical information. So that helps. The new proposal development is definitely helpful. And also about tracking the patients, because most of the patients coming with severe dehydration coming from the rural area. So this helps us to get everybody has their unique patient identification number. So this is what we have been doing. Obviously challenges are always there, because when we started this thing, there was especially among the nurses who have not been using these tablets and things like that. So very difficult for convincing, but as I said, it's a small area and we have international people working with us. So there was a timeline that either you have to work or you just quit the job. So they had to force and they get it. And now everybody are happy. It's so easy, so comfortable to doing that. So these are the advantages. Similarly, that helps in the logistics also, procurement things, how much misuse has really come down, financial benefits has been on the positive end. So now coming to, obviously I will talk more of a research end actually, since my experience in that. So what we have been talking over these last 2 years is that we know that Bangladesh is the challenge is we have transitioned from a low-wage, labor-intensive activity to a higher-wage, knowledge-based industry, and Bangladesh is trying in the both way. On the low age also, and also in the high age, what we have been talking here. And I think health sector is one of the field where these high-stake opportunities are much faster, and that needs to be focused in a big way. And especially when I talk from my end of clinical trial, we have a big opportunity in Bangladesh, because we have hospitals with large excess of population with different diversified disease, naive patient never been exposed, which in Western world is difficult to get patients sometimes. Equipment, education, all our medical schools are all in English, so which have a big advantages. Cost is less. Obviously, whenever a company or a contract research organization, they look size where we can do in a very in a cost-effective way and get a good data. So which is possible. And very interestingly, our Director General Drug Administration, one of the regulators, they in 2015 they made a guideline that any clinical trial has to come out through a contract research organization. So these have been growing in Bangladesh, which is also a very useful thing. Use of technologies. Like, I will give one example, as I will talk in my few of the examples that is where you are using a lot of technologies. So to give you some examples that, as was mentioned, that we have different departments, specialized hospital like oncology, then you say orthopedic, but data are very lacking. There's no. So this example I'm giving is back in 2014-15 because I've been doing clinical trial for almost 25 years. So I have a lot of international connections. So this person from Singapore was asking that the problem is the type of work that you do in ICDW is diarrheal disease, respiratory, which is obviously not a big issue in the developed world. So if had it been oncology, rheumatoid arthritis, diabetes, hypertension, we would have. So, okay, so it happened like that, they had a study. It was a biotech company based in Vancouver. They were doing, because lupus nephritis is one of the complications of systemic lupus that causes irreversible kidney damage. So in fact, exactly. So what happened is there's no licensed drug available at that time, and it was dependent on steroid, and long-term steroid, the problem is a lot of diabetes, hyperlipidemia, and all this issue. So they were looking for hospital for places where we can. So in Singapore, that CRO had a couple of hospitals in Singapore, South Korea, Taiwan, Thailand. But the problem was they were not getting patients because those countries, they have such a health system is so good that before going to that severe condition, they have been managed. So the inclusion criteria, like you have to have protein loss more 1.5 gram or more in the urine. So then they contacted me, and I talked with two of our renowned rheumatologists. One is medicine professors. So they said, patients are huge. We are always getting, but unfortunately we don't have any data. So give me a week time. So I will use 2 or 3 students at BSMMU, and the other one was at Sarvadi Hospital. So within a week, they gave us data, which was over 1,000 cases. So when I shared that, they said that, Vasi, the first thing what I wanted, I talked with my manager in the hospital that how often Singapore Airlines comes to Dhaka. The reason is I want to come and see, directly talk. And they said every day there's a flight at night. So he came, he said, please make sure those 2 investigators are there, I will talk. And they were convinced right away. And they said that, now it's my turn to convince the biotech at Vancouver that this is the place you have to come, you have to do the study. And as I said, that all this process and then IRB approval and all this, we were almost 8 to 10 months behind than the other sites. The total sample size was 265. And when we started, they were told if Bangladesh takes 10 patients, we are more than happy. So when 10, we got it about within 2 months. Then because you have inclusion, exclusion, you have to match all things. So from 10 to 15, 20, 25, 30, 45. They said, wait a minute, it's 46. The data will be skewed because the total it was a 79 center, 20 countries globally study, $120 million investment of that project. They said 46 is good enough for that. It was phase 2 trial and it was done. Then this was. I'm happy to say this year in January this drug got FDA approved. This is this. Yeah, this is a lupus. There's a voclosporin. Voclosporin. Yes. So you can go and say. So we were in the phase 2 trial. So because in our phase it was basically 2 different doses to decide which one to go, and from that study they went to the phase 3 where we were not part, but. FDA when they reviewed the phase 2 and phase 3 all about 533 patients, and their auditor came to Bangladesh to this hospital, and it was ultimately it was passed through. And as you can see, so these are the examples. We have the opportunity, we have the patient and load, but unless we don't tap those things, right now one of my other colleagues, Guillain-Barré syndrome is also a very big problem in this country, especially with bacterial and viral disease. So this guy, what he has done a lot of epidemiological paper, and that actually globally, those who are in the GBS field, they have found that this is a place to come, Bangladesh. And now they have, if you have gone to NIST, the National Institute of Neurological Science, Professor Deen Mohammad's hospital or Dhaka, they have made a state-of-the-art clinical trial unit where they are doing the phase 1, phase 2 trials. So this is another example. And saying this, in COVID we are not behind. In the COVID also we are doing one of the monoclonal trials. You might have heard that in COVID there is a very expensive drug, often tocilizumab, that's 70 to 80,000 taka is needed for one shot, which is often used. But this drug is used on a very late stage. But this is another drug, the Chinese company that we are in the complement pathway, we are using much ahead of that. And this is a trial that Bangladesh is participating. We are coordinating the study. And I just heard that last Saturday they had a global DSM. It's a multi-country study going on. The preliminary data shows that those who are getting this drug have significantly better improvement. They were looking into the respiratory requirements, support oxygen or not, and probably this DSMB, Data Safety Monitoring Board, have requested that you should consider for emergency use authorization. So you can imagine, so these are the things which we are giving the data to everybody else. So these are...
Just to ask you one question that's complementary is that, do you have these data sets available under certain license categories?
You know, the point is these all are...
Researchers are suffering.
Yeah, but point is these are still in the these are sponsors. You cannot take it at this. Yeah, you cannot share it. But saying this, in ICDDRB, I am doing malaria work for the last 10 years in Hilltrex. I have a field site. Humongous data. We started with Johns Hopkins Malaria Research Institute, but subsequently other funders are there. The problem is we have to always look for funding for my own stability and my staff. So data are huge. So what happened was... Not. So this is where I would request the university students, because because mostly what we can do is before the COVID, it was all Hopkins students coming doing their master's data and
chipping in, ICDDRB is a very insular organization.
Unfortunately, that's what I'm saying, that this is how CTD should think of.
There are some medicines, they have a pilot in a very remote village, you know.
I went into a partnership with ICDDRB in United Hospital about tuberculosis. I wouldn't go into the detail. After 2 years of partnership, I had to beg, writing a formal letter, and come out of it.
But I think things are changing. I would say now, we have a first time Bangladesh in 60 years executive director. Yes. So things are changing. We really want to collaborate with local university students. So
universities are just doing research based on MIT data.
Exactly. What I'm saying that Chittagong Hilltrex data is a huge data we have for demographic data. NCD we can look under non-communicable disease. So if there is CPD could help us in this.
That's what I was actually asking. Especially I will ask that today we should come up with a kind of a agenda for the coming time.
Yeah,
otherwise,
we can jointly raise funds.
No, but these data are giving us the funding, because when we share these things, they are coming out. So one thing just like I want to add, and before, as we know that we are moving towards a middle income country, especially we are always talking about our pharmaceutical sectors. They're getting this advantage because of the TRIP, this WTO, but what will happen once we go there, that won't be that easy, because then you have to give the royalty, you have to wait for the patent period. So those things so R&D in the pharmaceutical is almost lacking. And now, if you see in the last 2 years, China, who has been globally in the construction, but now they are in the health sector, not with the machineries, but with the products are going for research. And you have seen the Sinovac, Sinopharm, how many places they have done. Unfortunately, we were almost ready to start, but it didn't happen. So very recently, another company, Chinese, they are interested in preclinical trials in Bangladesh, and already we have done an NDA. The reason is that for the last 2 years, there has been really shortage of monkeys, especially the cynomolgus rhesus monkeys, which are required. So the problem is not, it is not that you like global. Yes, but like what Globe has been doing, they're catching some monkeys. So that won't be it. You have to properly breeding and do that. So they are interesting for this, and then drug development. And I think this will be a unique opportunity for Bangladesh.
We do have a monkey farming.
No, we can do because ICDs already have a small animal. We do have animal house like guinea pigs, mice. We are doing, but we have animal house. So we want to go to a bigger because non-human primates are needed before you go to.
We must have a kind of a travel. No, we should have a ICDDR study.
Why not? Please, definitely, you are most welcome. So we have department.
When they say
I'm very desperate. I really want to.
But when they say the China wants to do preclinical trial on monkeys, so these monkeys are defined, right?
No, because we have already found that these are rhesus monkey are available in certain part of the country, so they will buy a land, breeding for a big 10-acre land. So these are the discussion.
They will not come out of their shell.
No, this will be covered. And export. So this is a totally new field of research that can opportunity for young generation.
They will create a research and take all the monkeys for the restaurant.
No. So I'm just giving us ideas to use. So these are the opportunities we have.
Very interesting. Thank you.
Thanks.
Thank you for sharing.
Good insight, good
Thanks.
insight.
Probably you know about this. I know this person. That Oris Biotech. They're in the high tech, but they are developing this establishment of plasma transfusion. This is something they are doing. There's a $300 million project in the Kaliakor. So China is
it coming up with a...
Oh yes, structured building already. This is that they are doing. So what I'm saying, that China, Kaliakor High Tech Park. Right. So what I'm saying, that China has a tremendous interest on health sector and especially on the research. So this is where we should tap and get the opportunity in this region.
Gentlemen, you should all work on prevention, not going to doctors, Yeah, you have to be healthy, live a healthy life,
Thank you very much. Very insightful. I mean, I've learned so much in this session, in one session. I would come, we have 3 more speakers, but don't leave because we have a very small group of, samples, you can say. So, yes, now I'd like to call upon Professor Mohammad Sajjad Hussain, who is the Director at the Department of Electrical and Computer Engineering, and also NSU Startups Next. Yes, okay, at the North-South University.
So thank you. First of all, I'd like to thank you to invite me here. And so it's good that I am talking after Manjur Bhai. So I did not study or look into the papers, but I have some, let's say, observations kind of, especially Nadia's, weakest point, right? So slide number 26, other challenges. So he pointed out some challenges that challenged me. Okay? She, sorry. So let me just mention some of the challenges. Like qualification requirements for new jobs will become more stringent, and new skills and experience will be obligated, right? So new things will require. Upskilling and reskilling is nearly absent in the industry. That means industry is not even upskilling or reskilling, and 25% of the employees receive training from the company's own. That means other employees even do not receive, trainings. Labor skills are not at the requisite level. Universities' curricula are disconnected from market demands. So that's how I am challenged. Okay? Teaching method in Bangladesh is incapable of producing experts who meet market need, and IT graduates frequently find themselves unsuitable for job in the IT sector. So I really appreciate your courage, okay? That you invite IT professors and you are telling this thing. And believe me, I do not disagree with you, okay? I agree with you.
Oh, what a relief.
What a relief.
No, in fact, we are doing a study right now.
Right.
We are interviewing 100 employers
Right.
and 500 students to understand the skill gap, skill mismatch, and that's giving us. We have done studies also, so we have been quite blunt about it. But this is the real problem we feel.
Right. So what is the solution? What is your, let's say, suggestions on that? Is there any pathway to, or you just pointed out this thing? That's one thing. Okay. So I was just coming from one, meeting where our vice chancellor and the other deans and professors are there. So I was presenting about our startups next and how to connect, let's say, startups or industries to academia. So just, while I was listening this presentation, one question came out, okay, to my mind. Let's say, yes, government is upskilling, reskilling employees or many, let's say, IT skills or so on. So I was thinking, wouldn't it be better that faculty members I mean, skill those, I mean, in the right way, and that's what you are talking. The university is not producing, I mean, quality graduates. So the question is, faculty members দেরকে কি আপস্কিল করার দরকার আছে?
Of course দরকার আছে, সবারই আছে।
সবারই আছে?
সবারই দরকার।
Continuous process?
শুধু ডাক্তারদের দরকার নেই, তারা একবার once the doctor gets I have a
I'm accepting the sting.
no, but if you are in a FCPS, you know, if you are going for FCPS,
After that you don't need to do anything.
you don't need to do anything.
Or MD.
Yeah. FCPS 7 years.
Okay.
7 plus 5, 12 years.
It's a continuous process.
Okay, so the answer is, I mean, we need to upskill our faculties are also, right? So in Bangladesh, are we doing that? Upskilling our faculty members?
It's missing.
Completely missing.
And UGCS is coming.
They're both products of NSU.
I am from NSU.
Yeah, I know his face. I mean,
Undergrad and masters both in NSU. But I think in NSU they did some IT training for the teachers.
আমার
No,
একটা পয়েন্ট
no,
ছিল,
no.
আমার একটা ভেরি ইম্পর্টেন্ট পয়েন্ট ছিল ভাই, সবাই একটু জাস্ট শুনেন মনোযোগ দিয়া। এডুকেশন ইনস্টিটিউট গুলা 3 কোটি টাকা খরচ করে গেট বানাচ্ছে, লাইব্রেরিতে কোনো বই নেই, এই হলো অবস্থা আমাদের। ঢাকা বিশ্ববিদ্যালয় 4টা গেট বানাইছে বড় বড়, 3 কোটি টাকা খরচ করে। আপনি লাইব্রেরিতে যান, কোনো জার্নাল নাই। আমার ঢাকা কলেজ, যে কলেজের আমি ছাত্র, দেওয়াল এবং বানাইছে 5 কোটি টাকা খরচ করে, লাইব্রেরিতে কোনো বই নেই। আসলে আমাদের টোটাল প্ল্যানিং এক্সিকিউশন সব জায়গায় প্রবলেম আমাদের। আমরা অ্যাজ এ নেশন আমরা বুঝি না কোথায় টাকাটা খরচ করব, কেমনে খরচ করব, কনটেক্সটে কি করে চিন্তা করব।
I add to your comments.
Which it really disturbs me. Where to look into?
না, আমরা না, আমি একটু মঞ্জুবের সাথে অ্যাড করি কি, the equation of development is different now. আপনি ধরেন, you know, you are spending, let's say,
যদি আপনি এই যে এমআইটি তে রিসার্চ করেন, আমি দেখছি ইয়েলো রিসার্চ একই গ্যাপের কথা বলে সবাই। এভরিবডি যখন মাইক্রোসফট হায়ার করে, গুগল হায়ার করে, ইউ আস্ক গুগল সিইও হোয়াট ইজ ইওর বিগেস্ট চ্যালেঞ্জ, তার 1 নাম্বার চ্যালেঞ্জ হলো ফাইন্ডিং দ্য রাইট ট্যালেন্ট। পৃথিবীর বেস্ট ছেলে পেলে যায় তার কাছে, তারপর সেই কথা বলতে চায়। সো এরাও ট্রেনিং দেয়, এখানে সবাই ট্রেনিং ছাড়া তার কাজ কেউ করায় না। আচ্ছা ভাই, আপনি বলেন। না না, আপনার কথা শোনার দরকার আছে।
no, আচ্ছা, এখন আমি আমার স্টোরি বলি। Let's say I did good, I mean, score in my SSC, HSC, then came to BEd, and definitely not me, basically all the faculty members. They have brilliant, right? They are brilliant in their classes even. So they manage their own PhD, they get own funded, came back here, and after that, I mean, government is probably not spending any money to them. Exactly, right? And even what they are talking after coming back, they are not even listening to that, right? So Manjur bhai boli, I mean, you are an outsourcing company, let's say you do a lot of international works, and how many, I mean, employees you recruited from the government program, যে গভর্নমেন্ট প্রোগ্রামে তাদেরকে পিএইচপি শেখায় বা এইচটিএমএল শেখায় বা এরকম?
Zero. You're talking about
Zero. LICT project. Zero.
It's anyways.
তাহলে আমি যতগুলো চিনি, I mean, those who are the good in the outsourcing companies, everybody hires from the good graduate, Dhaka University, BUET or something, right? Because they need to compete.
Absolutely.
For the, I mean, things. এখন LICT project হয়তো আসছে few years back when we are thinking, oh my goodness, there is a huge money outsourcing these things and blah blah blah, and we want to grab this market. What we need to train a lot of people, train them, okay, and etc. etc. But I think nobody from educational institutions suggested that, who is in from computer science background or so.
আমি আরেকটা জিনিস কমপ্লিমেন্ট করি, এটা আমি সব জায়গায় এই গল্পটা বলি। একটা দেশ নেক্সট লেভেলে কেমনে যায়, ছোট্ট একটা উদাহরণ, এই যে আইওটি নিয়ে আমরা কথা বলি না, আগামীকালকে পাবলিক হেলথ ডিপার্টমেন্ট যদি বলে যে আমার কোনো বিল্ডিং আমি স্মার্ট বিল্ডিং ছাড়া করবো না, একটা ঘোষণা খালি, ইট ক্যান চেঞ্জ দ্য এন্টায়ার আইওটি ল্যান্ডস্কেপ অফ দ্য কান্ট্রি। আগামীকালকে 10,000 আইওটি লোক তৈরি হবে বাংলাদেশে, কিন্তু আমরা কিন্তু ওই মতো কখনো চিন্তাই করি না। আমরা এজ এ নেশন কনটেক্সচুয়ালি চিন্তাই করতে পারি না।
কিন্তু আমাদের তো বিপিও সামিট হয়েছে, আই রিমেম্বার আই অ্যাটেন্ডেড 3 সামিটস।
ওকে,
you attended BPO.
ওটা আমরা প্রচুর কথা বলি কিন্তু কোনো কিছু আসলে করি না।
এবং ওই সামিটে কিন্তু আপনাদের নর্থ সাউথের লিডার ছিল,
হ্যাঁ,
ফার্স্ট ওয়ান, যেখানে আমাদের পিএম এর হার সান হাত দিয়ে
Right.
হ্যাঁ, তো প্রথমটা, সেকেন্ডটা, থার্ডটা যেটা বসুন্ধরা, আই ওয়েন্ট টু দ্য ফার্স্ট 3। তারপর আমি একটা ধারা বুঝে গেছি যে এটা আসলে
মানে it's very
এগুলো সবাই খালি কথা বলে, পপ শোষা, কিন্তু কোনো নাথিং হ্যাপেন্স।
রিয়েলি প্রথম
you will be taken away.
এগুলো হলো সব মার্কেটিং গিমিক।
It's all political and other.
কল সেন্টারে
Yeah, AJ LICT is also political game. So আমার মনে হয় we will not bring that context actually. It's different. ওখানে অনেক
That means the right person needs to be in the right place.
Absolutely.
তাই না? তো তাহলে কি হলো আমাদের মানে so that was a, let's say I will say the blunder. Probably government spent a huge amount of money training those LICT. The purpose for what they trained, that purpose was not served. Now my question is, what we are doing for the next generation technologies to bring and etc., etc., is it going to be the same trap? And Manjur bhai already said,
the purpose is served.
I mean, gentlemen, I mean, আমরা একটা জিনিস যেটা সবসময় না সবসময় আমরা একটা জিনিস ভুলে যাই, সেটা হচ্ছে আমাদের এটা ইয়াং জেনারেশনের দেশ, দে উইল ফিগার ইট আউট। আমি যে এখন এই যে 20 বছর সামথিং পড়াপড়া হায়ার করি, দে আর সো ডিফারেন্ট। ওরা আমরা যেভাবে চিন্তা করি 50 বছর, ওরা ওইভাবে চিন্তাই করে না। So I am extremely, মানে optimistic that নতুন কামিং জেনারেশন is going to change the way Bangladesh operates. এটা আমি একদম ভিতরের কথাটা আমি বলতেছি। অ্যাপারেন্টলি এদেরকে মনে হয় খুবই ফ্লিমজি, ভেরি শর্ট নোটিস, শর্ট সেন্টার্ড, কিন্তু এরা মিথ্যা কথা বলে না। নতুন জেনারেশনের ছেলে পেলে আমাদের মতো এত মানে বাইচালি বুঝে না, এটা বলতে ওইটা বললাম, ওগুলো এরা বুঝেই না। দেয়ার ভেরি স্ট্রেট কাট, হবে তো হবে না, না হবে না। সেকেন্ড থার্ড জিনিস হলো এরা টেকনোলজি শেখে, ওরা টেকনোলজি খুব তাড়াতাড়ি শেখে। তো আমি আসলে সাজ্জাদ ভাই খুবই অপটিমিস্ট, বিকজ আপনার নতুন জেনারেশনের যে আপনার স্টুডেন্ট দে আর রিয়েলি গুড।
সেটা আমি বলছি না।
larger number of students coming to technology.
Yes, এটা আসতেছে।
হ্যাঁ হ্যাঁ, এটা আসতেছে, yes. হ্যাঁ, yes, more interest is coming.
Yes.
The percentage of girl children, they are
Pretty high এখন।
Pretty high. আগের চেয়ে অনেক high, আগের চেয়ে অনেক
Girl
high.
is in ULAB is 60%.
60% মেয়ে,
60% girl.
বুয়েটেও তাই, আইটিতে 60% মেয়ে।
IT-te.
আইটিতে
Yeah, IT girls are more now.
okay. So let's
Okay, so fourth industrial revolution, Manjur bhai already said an example. I mean, you developed a product in collaboration with Stanford University in the US. তাহলে কি হলো, যে ইনোভেশন বা যে জিনিসটা লাগবে, so he is going to Stanford University, and that university research needs to be connected with the industry. So that
Absolutely.
So where is this one in my country?
No, it's a
কোনো
mistake.
link.
Absolutely.
So why it is missing? Let us find out those points and try to address those things. Okay? This is very important. Another thing, cross-disciplinary things has to be there. Madam উনি বললো যে I could not have some trouble, I mean, doing some things, right? Probably you yourself tried to do this thing. You could bring some business people, you could bring some sociology people who understand the, behavior of our local context. Probably they could guide you. Just when you do a project, okay? So same thing, let's say ICDDR ক্ষেত্রে বলা হলো insular, cross disciplinary কিভাবে করা যায়, how to motivate people, ওই জায়গাগুলো আমরা হয়তো কাজ করতে পারি। Okay.
Manju bhai, there's tea, coffee. Just some refreshment.
Okay, so far it's my feel.
Time.
Okay, okay, thank you. Okay, that's all from my side. তারপরে আমরা যে দুইটা তিনটা পয়েন্ট বললাম যে একটা ইন্ডাস্ট্রি একাডেমিয়া কোলাবোরেশন কিভাবে করা দরকার, আমাদের ইউনিভার্সিটির ফ্যাকাল্টিদের হাউ উই ক্যান ব্রিং টু ইন্ডাস্ট্রি, অথবা ইন্ডাস্ট্রি যে এখানে কেন কাজ করতে পারছে না, বাট দ্য সেম ইন্ডাস্ট্রি ফ্রম আওয়ার কান্ট্রি হি ইজ গোয়িং টু স্ট্যানফোর্ড ইউনিভার্সিটি. I was chair of Department of EC at NSU. That time, one entrepreneur from our country, he came to me. He was basically developing a bot, a robot kind of thing that will I mean swim in the pond and through and by its camera images it will look into its fishes. Okay, the fish gular, I mean how big it is, how much food it needs, and etc. When to play. So it's an IoT based project. So what he did not get any support from any university from our country or probably anywhere. So he went to South Korea, and there he presented his idea, and one of the universities he get a grant that one of the South Korean university will develop a prototype for that. So as ICGRB or whatever we are doing, basically we are giving them data to John Hopkins or the other thing. Even in my university NSU there is a project from John Hopkins University. So why they are investing? They are basically collecting data and everything. They will do some research, make some products, and that will be applied to you. So South Korea University, they will build a prototype for that because they need ponds in my area. It is not there in South Korea. They will develop it. Once they develop it, that entrepreneur will use it and probably they will market to the whole South Asia. So that's how basically research and let's say entrepreneurship develops and society is benefited. So in that direction we can basically look into if we really want to do something sustainable. Thank you.
Thank you very much. Thank you. Very, very, pertinent issues actually. So we are also doing some work. Again, interdisciplinary, exactly. Research is so important because when I started doing this work with FES, I was really scared that, what people would say, we have no knowledge of technology, but you see there are many aspects of it. So knowledge from every sector makes it more, more robust. Actually, so I think I will bring Dr. Joardar later because you are a public health person, and now I would come to Dr. Arif Mahmood, who is the Deputy Director, Medical Services, Evercare Hospital, Dhaka.
ফামিদা আপা, আমি একটু বিদায় নিতে চাচ্ছি, যদি মাফ করেন। আমার 7:30টায় আর একটা প্রোগ্রাম আছে, তার মধ্যে বাসায় গিয়ে পৌঁছাতে হবে। ভালো থাকবেন। খুবই সুন্দর ডিসকাশন হয়েছে এবং স্যার আপনারা খুবই ফ্রুটফুল আলোচনা করেছেন। আবারও দেখা হবে ইনশাআল্লাহ।
থ্যাংক ইউ ভেরি মাচ এর জন্য। হ্যাঁ, জি, ভালো থাকেন। হ্যাঁ,
থ্যাংক ইউ. Thank you for organizing such a important dialogue on the future of the work in Bangladesh. So I'd like to thank Hamida Khatun, then the FACE for inviting us in this dialogue. And already we have passed more than 2.5 hours, and we are really tired, and nobody has the concentration to listen. So, but I should. But as per so many teachers, I can see here, Professor, any session more than 1 hour, we cannot keep the concentration. And if we take a session of 1 hour, then 40% can remain in the brain. So after 2.5 hours, definitely what you are saying, it will not reach to the optimum level. But however, I should appreciate the effort, and I should thank Sadat and Naurin for their wonderful presentation, their effort. And I would like to thank the dignitaries because I have learned so many things about the IR and the implication in the health sector. As being a doctor, it is really quite challenging in Bangladesh to implement this 4th IR in the healthcare sector. The problem is that everybody has said, you see that no value to talk at this moment. So no, it's all right. I have learned everything. I try to help you out, and
these are very important for us.
Any support you need one from me as I am a public health expert and as well as a hospital administrator since my earlyhood, my medical school life. I never practiced clinical things. So I'll be very happy to support you at this program. But there is a lot of application application we can use in the health sector. But the problem is that in the health sector we have achieved so many things. Like MDG we have achieved, our life expectancy has increased, infant mortality, MMR has reduced. So that is fantastic. We got so many awards, our Prime Minister got so many awards. Recently SDG, she got award. But the problem is that our healthcare system, though it is very systematic, like the Union Council level to Upazila, district, divisional, but the distribution of healthcare delivery system is not appropriate. If you look at the facility during the COVID time, we have learned that we have 1500 bed for the critical care, but out of 80% of this bed in the Dhaka. So you think rest 20 is outside the periphery for the peripheral people. So all the doctors practicing in the Dhaka base or some divisional Chittagong or some Sylhet base, they are not going to periphery. So our general people is not getting any benefit whatever we provide. So, but I am sure with this, the outcome of this research work will help us to do something. And regarding the artificial intelligence, I can see the huge prospect in Bangladesh. The robot, you see our neighboring country, India, their government sector has the robot. So 17 hospitals I visited, they have the robot. With the robot, they do the surgery. Outcome is so good. It is about precision and the tissue cutting. So all these things very good by the robot. But we tried 2008 to bring robot in Bangladesh, but nobody interested. No doctor, as somebody was saying, doctor are not interested to learn. They are not interested to go for the training, development, so that is the problem. And also about that, another artificial intelligence is very important in Bangladesh. We are doing so many misdiagnoses. People are going from here and there with files, X-ray, CT scan, they are not getting the right diagnosis. So to prevent that, we need the artificial intelligence in our CT scan or MRI, so that we can, there should be differential diagnosis, so there is accurate diagnosis, accurate treatment and accurate outcome. So that is very important, and we have to focus, because all these things is very costly business in the health sector. So we need to, someone was talking, Shakufa was talking about the healthcare finance, insurance. So if you see the percentage, it is very less than 5% in Bangladesh. But still people, government is working on the universal health coverage. I am sure within 2030 it will be achieved. But to do that, we need to do a lot of work in this insurance. And for the development purpose, we have to look into the PPP model, public-private partnership. Otherwise, that fourth IR is very difficult to implement in Bangladesh, because who will invest? So create a hospital, the entrepreneur has to invest 1,000 crore of money, but on return he has to wait 5-6 years to get the money back. So he will not interest. They are not interested. You see, last 15 years, how many big hospitals come in the Bangladesh? Only 8-10, very limited. But they would like to put money in other sector because the return is very easy. So for this reason, there are a lot of model on PPP. Our neighboring India, Vietnam, Philippines, everybody has improved their healthcare. Malaysia with this PPP model. So we need to pass this message to the health authority or the Ministry of Health or other partners. So we need to do something. Otherwise, with the individual money, it is not possible. We cannot reduce the cost. If this out of the pocket cost, everything. So with that, I'd like to conclude here. I enjoyed the session. I learned a lot of things. I enriched by your knowledge sharing thoughts. But finally, I would like to thank this young guy. He spoke to me about this interview, so interact. And I also appreciate this home care model, which is very popular in outside Australia, Europe. It is very, very good technique for the creating the provide the service to the patient. But unfortunately, there is legal issues. Besides that, other issues also. You will not get the right people, because in our country there is a supply-demand gap. Like the doctor and nurse, what we need to have in our country to provide the healthcare delivery system, but we are huge lacking. As per the WHO, we need 3 lakh nurses, but only we have 75,000. So how can we provide ensure the quality service? So this is the challenges. But I am sure the way we are coming forward, there should be some way out to develop our healthcare. Thank you, everyone.
Thank you very much, Dr. Arif Mahmood. So yeah, you had provided us information through the interview. Thank you, and thank you for coming over once again. So now, last but not the least, as I mentioned that he's a public health analyst. So Dr. Tawfiq Joardar, who is the Vice Chairperson of Public Health Foundation Bangladesh. So he has done a lot of research on healthcare in Bangladesh. So over to you, Dr. Joardar.
Thank you, Fahmid Appa. আমি তৌফিক জোয়ারদার। আমি বেসিক্যালি জনস্বাস্থ্য বিশেষজ্ঞ, কিন্তু আমার পড়াশোনা হেলথ পলিসি এন্ড হেলথ সিস্টেম নিয়ে। এই ব্যাকগ্রাউন্ডটা বলে দিচ্ছি যাতে কনটেক্সটটা বুঝতে সুবিধা হয় যে যে কথাগুলো আমি বলছি সেগুলো কেন বা কোথা থেকে আমি বলছি। আমি দুটো পয়েন্টের উপরে কথা বলবো এবং চেষ্টা করব আমার জন্য বেঁধে দেওয়া যে সময় আছে 7 মিনিট বলেছিলেন সেটার মধ্যে থাকার। প্রথমে আমি রিসার্চ স্পেসিফিক দু একটা কথা বলতে চাই এবং এরপরে ইন জেনারেল ফোর্থ ইন্ডাস্ট্রিয়াল রেভলিউশন এবং সেখানে হেলথ পলিসি এবং হেলথ সিস্টেমের ইমপ্লিকেশনটা নিয়ে আমি একটু কথা বলতে চাই। রিসার্চ নিয়ে আমরা দেখেছি যে প্রথম কথা হচ্ছে যে রিসার্চটা খুবই চমৎকার হয়েছে, খুব ভালো লেগেছে প্রেজেন্টেশন। ইট ওয়াজ অ্যাকচুয়ালি ভেরি গুড প্রেজেন্টেশন এবং মেথোডোলজিক্যালি যথেষ্ট অ্যাডভান্সড। আপনারা যেই পদ্ধতিগুলো ব্যবহার করেছেন সেগুলো যথেষ্ট অ্যাডভান্সড এবং ভালো পদ্ধতি বা মেথোডোলজি আপনারা অ্যাপ্লাই করেছেন, কোয়াসি এক্সপেরিমেন্টাল যদিও, বাট ইটস আ ভেরি গুড ওয়ান। কিন্তু কিছু টার্মিনোলজি নিয়ে আমার কিছু ফিডব্যাক আছে। যেমন আমরা হেলথ কেয়ার, ফাহিদ আপা একটু আপনার অ্যাটেনশন সিক করছি, হেলথ কেয়ার, হেলথ সার্ভিস, হেলথ সিস্টেম, এই শব্দগুলোকে আমরা খুবই ইন্টারচেঞ্জেবলি ব্যবহার করি, কিন্তু এগুলোর কিন্তু ইমপ্লিকেশন খুব মারাত্মক যদি প্রপারলি না বুঝি যে কোনটা বলতে আমি কি বোঝাতে চাচ্ছি। এখানে টাইটেলে বলা হয়েছে ট্রান্সফর্মিং বাংলাদেশের হেলথ কেয়ার ইন দ্য ফোর্থ ইন্ডাস্ট্রিয়াল রেভলিউশন, ওয়ারেজ এখানে যে চারটা উদাহরণ আমরা পেয়েছি তার মধ্যে একটাও কিন্তু হেলথ কেয়ার রিলেটেড না, ছিল হেলথ সার্ভিস এবং হেলথ সিস্টেম রিলেটেড। তাহলে এটা ইটস নট এ বিগ মিস্টেক। আমি যেহেতু এই বিষয়ে পড়াশোনা করেছি সেজন্য আমি বলছি, কিন্তু আমার কাছে মনে হয় যে সবার জিনিসটা বোঝা দরকার এবং কেন বোঝা দরকার সেটা আমি একটু পরে বলছি। হেলথ কেয়ার হচ্ছে যে একটা পেশেন্টের সাথে ডক্টরের ইন্টারফেস, সেটা হচ্ছে কেয়ার। আমি একজন নার্স, আমি কেয়ার দিচ্ছি, আমি ডক্টর, আমি কেয়ার দিচ্ছি। সো ইটস এ রিলেশনশিপ বিটুইন আ ডক্টর এন্ড দ্য পেশেন্ট। আমি আসছি, আই এম কামিং টু দ্যাট। হ্যাঁ, এটা বেসিক্যালি দুটোর মিক্সচার, যেটা আসলে কোনো একাডেমিক্যালি এটা আসলে খুব একটা ভ্যালু নেই শব্দটা। এটা হচ্ছে কেয়ার। তো আমি যখন হেলথ কেয়ার নিয়ে বলছি বা এআই নিয়ে কথা বলছি হেলথ কেয়ারে, মূলত আমি কি নিয়ে কথা বলছি? ওয়ারেবল সেন্সরের কথা বলতে পারি, অথবা জিন টেকনোলজি, জিন এডিটিং এর কথা বলতে পারি, অথবা দিস আর ভেরি মাচ কেয়ার রিলেটেড, যে একজন ডক্টর ওই কেয়ারটা একজন পেশেন্টকে দিচ্ছে, and you are doing a research on that. That's actually a healthcare research where exactly. হ্যাঁ, আচ্ছা, তারপর হচ্ছে সার্ভিস। হেলথ সার্ভিসটা কি? সেটা হচ্ছে যে ইন্টারফেস বিটুইন দ্য সার্ভিস প্রোভাইডার অ্যান্ড দ্য ম্যানেজার্স। যে একটা সার্ভিসকে আমি কিভাবে দেখি, ইলেকট্রনিক হেলথ রেকর্ডস আমার কিভাবে চলবে, একটা হাসপাতালে রোগী আসবে তার ফ্লোটা আমি কিভাবে মেনটেন করবো, একটা ডাক্তার হাসপাতালে আসছে কিনা সেটাকে আমি কিভাবে মনিটর করবো। সো ইটস নট রিয়েলি অ্যাবাউট দ্য পেশেন্ট, ইটস অ্যাবাউট how the managers are managing the services provided by the service providers. So it's about the service, it's not about care. যেমন এখানে আপনাদের উদাহরণের মধ্যে আমি বলতে পারি যে কোনটাকে যেমন এই যে ব্লকচেইন রিলেটেড যে ইলেকট্রনিক হেলথ রেকর্ড, ইটস অ্যাকচুয়ালি অ্যান এক্সাম্পল অফ হেলথ সার্ভিস। তারপরে প্রিভেন্টিভ মেশিন লার্নিং এর কথা বলছি, এটা এক ধরনের সার্ভিস ওরিয়েন্টেড। আপনি সার্ভিসটা আপনি বাসায় ইয়েতে দিচ্ছেন, মানে কিভাবে দিচ্ছেন সেটার উপর কিছুটা ইয়ে আছে। তারপরে হোম হসপিটাল যেটা, সেটাও হয়তো এটা কেয়ার এবং সিস্টেম দুইটা ইয়েতেই ফেলা যায়। আর ফাইনালি হচ্ছে হেলথ সিস্টেম রিসার্চ, যেটা একটা হসপিটালকে কেন্দ্র করে না, এটা অ্যাবাউট দ্য ওভারঅল পলিসি অ্যান্ড দ্য সিস্টেম। যেমন আপনি DHIS2 এর কথা জানেন, এই যে ডিস্ট্রিক্ট হেলথ ইনফরমেশন সিস্টেম, ইটস নট অ্যাবাউট আ পার্টিকুলার হসপিটাল, ইটস হাউ ইউ লিঙ্ক আপ দ্য হোল কান্ট্রিজ হেলথ ইনফরমেশন সিস্টেম। সো দ্যাটস অ্যাবাউট দ্য সিস্টেম। কেন আমি এটার কথা তুললাম? এটার কথা বলছি এই কারণে নয়, ইটস নট জাস্ট অ্যাবাউট দ্য নমেনক্লেচার, এটার ইমপ্লিকেশন আছে। যেমন আপনি এআই এর মাধ্যমে হেলথ সার্ভিসটাকে ইমপ্রুভ করলেন অথবা হেলথ কেয়ারকে ইমপ্রুভ করলেন, ডাজ ইট necessarily improve the health system? ফর এক্সাম্পল, আপনি খুব হাই এন্ড দুটো হসপিটাল যেমন এখানে আছে নেভার কেয়ার অথবা ইউনাইটেডে, আপনি রোবোটিক সার্জারি শুরু করলেন, উইল ইট বি ইকুইটেবল ফর দ্য পিপল? উইল ইট রিচ টু দ্য মার্জিনালাইজড পিপল? সমাজের যে প্রান্তিক জনগোষ্ঠী আছে, আমরা যদি এআই আমরা ডেভেলপ করছি, ফোর্থ ইন্ডাস্ট্রিয়াল রেভলিউশন আমরা ঝাঁপিয়ে পড়ছি, কিন্তু তার বেনিফিটটা আমার পলিসিতে এমন কোনো পলিসি নেই যে পলিসির মধ্য দিয়ে আমি আমার প্রান্তিক জনগোষ্ঠীর কাছে এই বেনিফিটটাকে নিয়ে যেতে পারি। সেটা যদি আমার মানে সেই পলিসি লেভেলের ডিসকাশনটা যদি আমার না থাকে, আমি খুব রিসার্চ করলাম হেলথ কেয়ার নিয়ে, কিন্তু আমার হেলথ সিস্টেমটা সেই যে তিমিরে ছিল সেই তিমিরে রয়ে গেল, তাহলে কি কোনো লাভ হবে? কাজে আমাদের এই ডিসএগ্রিগেশনটা করতে হবে যে আমি আসলে কি নিয়ে রিসার্চটা করছি এবং তার বেনিফিটটা আমি কিভাবে পৌঁছাতে চাই। ইজ ইট ইকুইটেবল? ইজ ইট রিচ দ্যাটস ওয়াই ইটস ভেরি ইম্পর্টেন্ট যে আমার এই টার্মিনোলজিগুলো আমার বোঝাটা জরুরি এবং ওই কি নিয়ে গবেষণাটা করছি সেটা ডিফাইন করাটা জরুরি। এবার আমি একটা মানে একটু ওভারঅল কথা বলবো, 3 মিনিট সময় নিব। সেটা হচ্ছে যে যখন আপনি এআই নিয়ে কথা বলবেন, ফোর্থ ইন্ডাস্ট্রিয়াল রেভলিউশন নিয়ে কথা বলবেন এবং সেখানে মানে ফিউচার অফ দ্য ওয়ার্ক এই শব্দটা থাকবে, তখন আমরা আসলে কি নিয়ে চিন্তা করতে পারি? আমরা চিন্তা করতে পারি যে এটার ইম্প্যাক্ট বেনিফিশিয়ারিদের উপরে, বেনিফিশিয়ারিদের কাছে যাচ্ছে কিনা, এক। 2 নম্বর হচ্ছে যে ফিউচার অফ দ্য ওয়ার্ক and its impact on the people who are basically working, the doctors, the nurses, all types of service providers. Future of the work and the intersection between different sectors. যেমন এখানে আইটি নিয়ে কথা বলছি, ওনারা তো হেলথের মানুষ না, তাহলে আমার দেখতে হবে যে ওনারা আর দে কমফোর্টেবল, ডু দে হ্যাভ ক্যাপাসিটি, আর দে রিয়েলি আন্ডারস্ট্যান্ডিং দ্য নুয়ান্সেস ইন দ্য হেলথ সেক্টর। এই জিনিসটা নিয়ে আমাদের গবেষণা হতে পারে। হতে পারে যে হেলথ সার্ভিস, হ্যাঁ মানে যেমন হেলথ সার্ভিস এবং হেলথ সিস্টেম রিলেটেড যে পলিসি ইস্যুস গুলো আছে সেটা নিয়ে গবেষণা হতে পারে। সেখানে হয়তো আমার টেকনোলজি খুব ভালো মতো জানার দরকার নেই, কিন্তু বাংলাদেশের পলিসি লেভেলটা আমার খুব জানা দরকার, সেরকম গবেষণা হতো। অর্থাৎ গবেষণা শুধুমাত্র কেয়ার নিয়ে না, এটা ইন্টারসেক্টরালিটি নিয়ে হতে পারে, এটা পলিসি নিয়ে হতে পারে, ইট ক্যান অ্যাকচুয়ালি এনকম্পাস আ লট অফ ডিফারেন্ট থিংস। এখন চ্যালেঞ্জেস গুলো কোথায়? ইন্ডাস্ট্রিয়াল রেভলিউশন নিয়ে যখন আমরা গবেষণা করি, তখন গবেষণা বা কাজ করি, সেখানে আমার চোখে পড়েছে যে আলোচনাগুলো, সেখানে 3টা মেজর ইস্যু চোখে পড়েছে। একটা হচ্ছে এথিক্যাল ডাইলেমা, 2 নম্বর হচ্ছে রেগুলেটরি ডাইলেমা, আর 3 নম্বরটা হচ্ছে যে হিউম্যান ইন্টারাকশনের ডাইলেমা। এথিক্যাল ডাইলেমাটা কি? যেমন মনে করেন একটা গাড়ি যখন অ্যাক্সিডেন্ট, যদি এখন একটা গাড়ি মনে করে যে এআই দিয়ে চালানো হচ্ছে, আমি যদি নিজে চালাই, আমি ক্যালকুলেট করব যে আমি যদি অ্যাক্সিডেন্ট করি তাহলে হয়তো একজন মানুষ মারা যাবে, আর যদি আমি অন্যদিকে ঝাঁপ দিই হয়তো বেশি মানুষ মারা যাবে, কিন্তু একটা বাচ্চার জীবন আমি বাঁচাতে পারবো। হুইচ ডিসিশন উইল আই টেক? শুড আই সেভ, মানে আমি কি একটা বাচ্চার জীবন বাঁচাবো নাকি 2জন বৃদ্ধ মানুষের জীবন বাঁচাবো? মানুষ কিন্তু সেখানে রেশনাল হতে পারে না। হয়তো রেশনাল থিঙ্কিং যখন আমি করি তখন আমি 2জন মানুষের জীবন বাঁচানোর কথা চিন্তা করবো, এআই আপনাকে ওই পথে পরিচালিত করবে। আমি আরেকটা উদাহরণ দিই হেলথ কেয়ার থেকে। জেনেটিক স্ক্রিনিং হয়, জেনেটিক স্ক্রিনিং এ হয়তো বললো যে একটা মানে হয়তো এখন আমরা সব ব্লাড টেস্ট এআই এর মাধ্যমে করছি, এআই আমাকে বললো যে হ্যাঁ এই আপনার ব্লাডের মধ্যে এমন একটা জেনেটিক ম্যাটেরিয়াল আমরা পেয়েছি যেখান থেকে বোঝা যাচ্ছে যে আপনার 80% চান্স আছে ব্রেস্ট ক্যান্সার হওয়ার। তো তখন প্রশ্ন আসবে যে can we prevent it? Can we do anything about it? No, there is nothing about it, nothing you can do apart from doing a mastectomy, just মানে কেটে ফেলে দেওয়া ছাড়া এটার কোনো উপায় নাই। সো আপনি যদি এআই এর কথা শোনেন, এআই এর কথা অনুযায়ী আপনাকে সেটাই করতে হবে, বাট উইল ইউ ডু দ্যাট? সেটাকে আপনি করবেন? So it's an ethical dilemma. I mean, how you go about it, we really don't have a right answer to it. So these are the ethical issues. নেক্সট হচ্ছে যে আপনার রেগুলেটরি ডাইলেমা, যেটার কথা অনেকেই বলেছেন যে আমার কাছে এআই আছে, আমি মানুষকে নিয়ে সেটা অ্যাপ্লাই করতে যাব, আমার কান্ট্রির রেগুলেশন সেটাকে অ্যালাউ করে কিনা। যেমন আমি একটা পেয়েছি, একটা ডিভাইস পেয়েছি জনস হপকিন্স ইউনিভার্সিটি থেকে, সেটা তারা অ্যাপ্লাই করে যে বাচ্চাদের চেস্ট সাউন্ড শুনে সে বলে দেয় যে তার মারমার আছে না কি আছে, তার কি এআরআই আছে কিনা, এই জাতীয় বিষয়গুলো সে বলতে পারে। এখন এটাকে যদি আমি ম্যাস লেভেলে ইন্ট্রোডিউস করতে চাই, এটার জন্য আমার ডিজিডি এর অ্যাপ্রুভাল লাগবে। এই যে আপনার কি জানি ওনার নাম ভুলে যাচ্ছি, ডক্টর জাফরুল্লাহ চৌধুরী যখন করতে চাইলেন, আপনার ওই টেস্টটা অ্যাপ্লাই করতে চাইলেন, তার আগ পর্যন্ত ডিজিডি এর অ্যাপ্রুভালের প্রসঙ্গ কোনোদিন আলোচনাই হয়নি বাংলাদেশের ইতিহাসে আমার মনে হয়। আপনারা কত টেকনোলজি, কত টেস্ট নিয়ে আপনারা কাজ করেছেন, আপনাদের হসপিটালগুলোতে কত টেস্ট পাওয়া যায়, কয়টা টেস্টে আপনার ডিজিডি এর অ্যাপ্রুভাল নিয়েছেন, কিন্তু ওইখানে কিন্তু এই প্রসঙ্গটা এসছে এবং তখনই এই কথাগুলো এসছে যে কিভাবে আমরা এগুলোকে অ্যাপ্রুভাল নিব ইত্যাদি। তার কোনো কাগজপত্র এতদিন পর্যন্ত ছিল না, এখন এগুলো তৈরি হয়েছে। বাট দেয়ার ইজ আ রেগুলেটরি গ্যাপ, ম্যাসিভ রেগুলেটরি গ্যাপ in introducing AI, এবং এটাকে অ্যাড্রেস না করে আপনি কখনোই এআই এর কোনো কিছুই একটা পদক্ষেপ নিতে পারবেন না, unless you are blessed by the political, যাই হোক এটা নিয়ে কথা না বলি। নেক্সট হচ্ছে যে 3 নম্বর যেটা প্রবলেম, যে হিউম্যান ডক্টর পেশেন্ট রিলেশনশিপ। আমরা যে বিএমডিসি থেকে মানে ইয়েটা পাই, লাইসেন্সটা পাই প্র্যাকটিস করার জন্য, আমিও ডাক্তার বাই দ্য ওয়ে, প্র্যাকটিস করি না, কিন্তু কতগুলো আমার কারিকুলামে কতগুলো বিষয় ছিল, তার মধ্যে কিন্তু এবং সেইগুলোর আলোকে কিন্তু আমাকে বিএমডিসি রেজিস্ট্রেশন দেওয়া হয়েছে, কিন্তু সেখানে কোথাও ছিল না যে আমি টেলিভিশনের স্ক্রিনে একজন পেশেন্টের কথা শুনে আমি এই প্রান্ত থেকে ডায়াগনোসিস করবে, প্রেসক্রিপশন লিখবে, এইটার ভিত্তিতে কি আমি আমার লাইসেন্স পেয়েছি? এইটা তো অ্যাপ্রুভ না আদৌ। তাহলে হাউ ডু ইউ রিয়েলি ডু দ্যাট? আমার বিএমডিসি রেজিস্ট্রেশন তো আসলে এই কভারেজটা আমাকে দেয় না যে আমি টেলিমেডিসিন করবো। এই প্রশ্নটা হয়তো কেউ তুলছে না, বাট এই প্রশ্নটা যদি আসে, আমি তো একটা আইনগত জটিলতায় যদি আমাকে ফেলতে যাবে কিন্তু পড়ে যেতে পারি। যে আমি হয়তো টিভি স্ক্রিনে একজনের কথা শুনে আমি একটা প্রেসক্রিপশন দিলাম এবং সেই রোগীটা মারা গেল, তারপর সে যদি আমার বিরুদ্ধে কেস করে, আমার লাইসেন্স বাতিল হয়ে যেতে বাধ্য। কারণ আমার লাইসেন্স কখনোই টেলিমেডিসিনের মাধ্যমে দূর থেকে একজনকে ট্রিটমেন্ট দেওয়ার জন্য ইকুইপড না। তো এই জিনিসগুলোকে যদি আমরা আমাদের পলিসি লেভেলে অ্যাড্রেস না করি, লাইসেন্সটা বলা নাই, কিন্তু লাইসেন্সটা দেওয়া হয়েছে আমার কারিকুলামের ভিত্তিতে, আমার কারিকুলামে তো ওটা নাই। এবং আমার যে ওথটা আছে, আমি যে প্র্যাকটিস গুলো করি, ফাঁক দিয়ে বের হওয়া হয়তো যাবে না, উই ডোন্ট নো রিয়েলি, বাট দেয়ার আর লুপ হোলস। দ্যাটস দ্য থিং, যে আমার রেগুলেশন গুলো এখনো এই এআই কে অ্যাড্রেস করার মতো ইকুইপড না। দ্যাটস দ্য বটম লাইন। এই জিনিসগুলো আমার চিন্তা করতে হবে। তো এই আমার আরো কিছু আছে, যে আরো কিছু আলোচনা আছে, আমার মনে হয় যে আমাদের আলোচনার সময় শেষ হয়ে গেছে, আমি সময় নিয়েছি। তো না, এই যে টেকনোলজিক্যাল এই ডেভেলপমেন্ট গুলোর জন্য আরেকটা প্রসঙ্গ যেটা এসছে, যে আমাদের জব কি চলে যাবে কিনা। দেখেন, আপনি আমাদের যদি এখন মনে পড়ে, আজ থেকে 5-6 বছর আগে কিন্তু আমরা উবার দেখি নাই। এই 5 বছর আগে আমরা রাস্তায় কিন্তু ইয়েদেরকে দেখি নাই, যারা সাইকেল চালিয়ে যে কুরিয়ার, এখন আপনি দেখেন যে ওই যে ফুড পান্ডার নিয়ে হ্যাঁ পাঠাও, এগুলো কিন্তু সব টেকনোলজি। টেকনোলজি জব যেমন নিয়ে যায়, নতুন জব তৈরি করে। সেই জন্য টেকনোলজি আসলে কোনো প্রবলেম না, ইটস এ ম্যাটার অফ রেগুলেশন। আপনি এটাকে কিভাবে রেগুলেট করবেন? আপনি কি জিন এডিটিং করে একটা মানুষকে বানর বানিয়ে দিবেন? এটাকে অ্যালাউ করবেন যদি আপনার হাতে সেই টেকনোলজি থাকে? আপনার রেগুলেশনটা ইম্পর্টেন্ট, আর জব ট্রান্সফরমেশন হয়। আপনি দেখেন, একটা সময় আমরা যখন ছোট ছিলাম, সপ্তাহে আমাদের একদিন ছুটি ছিল, শুক্রবারে। তারপর এক সময় শুনলাম যে বৃহস্পতিবারে হাফ, শুক্রবারে ফুল ছুটি। তারপর এখন শুক্র শনি 2 দিন ছুটি। ইউরোপের অনেক দেশে 3 দিন ছুটি। আপনার জব যদি চলেছে, আপনার আসলে জব যাবে না, যেটা হবে আপনার লেজার টাইমটা বাড়বে, যেটা নিয়ে আপনি অন্য কিছু চিন্তা করতে পারবেন, আপনি সময় দিতে পারবেন পরিবারকে। আপনি হয়তো 7টা দিন ব্যস্ত থাকতে হবে না, আপনার ওয়ার্কিং আওয়ার কমে আসবে। আর এটাকে অ্যাড্রেস করতে হলে আরেকটা জিনিস, যেটা আমরা পাবলিক হেলথ প্রফেশনালরা খুবই প্যাশনেট অ্যাবাউট, সেটা হচ্ছে ইউনিভার্সাল বেসিক ইনকাম। আমরা ইউনিভার্সাল বেসিক ইনকামের কথা বলি, বাংলাদেশে এগুলো এখনো অনেক সুযোগ পাওয়া হতো, কিন্তু আমি মনে করি যে আমরা যদি একটা রেগুলেটেড 4th ইন্ডাস্ট্রিয়াল রেভলিউশনের মধ্যে যাই, সেখানে ইনঅ্যাডভার্টেন্টলি অবভিয়াসলি যে আলোচনাটার সাথে সাথে আসা উচিত, সেটা হচ্ছে ইউনিভার্সাল বেসিক ইনকামের আলোচনাটাও আসা উচিত। যে যদি টেকনোলজির কারণে জব চলে যায়, তারপরে যেন একজন মানুষ সার্ভাইভ করতে পারে। রাষ্ট্রের দায়িত্ব জনগণের সেই সেবাটা, সেই আর্থিক সংগতিটা নিশ্চিত করা রাষ্ট্রের দায়িত্ব, এবং সেটা যেন আমরা করার চেষ্টা করি। ধন্যবাদ।
Thank you, Jawardar. I think I was intentionally, keeping you wait to talk about these issues, which were, which is also very important. You can't really complete a discussion on 4th Industrial Revolution and technology, health care or health service without looking into these, ethical issues and regulatory issues and access to also these services and benefits. So I think I will not summarize and also I wouldn't make any concluding remark. Instead, I would just thank you once again for coming over and sparing your time, valuable time, but enriching us with so much knowledge and so much information that our research which has been done, it will be improved significantly with your, the input we have got today. So we'll accordingly revise our report. But this is not the end. I would say that this is just the beginning. Cross fertilization of knowledge. That's very important, and we have learned today. Thank you very much. We wish you have a good evening. Thank you.